Hello, friends. We have to stop meeting like this, talking about criminal cases with healthcare employees who are getting criminally charged for, making errors that are bad errors, but they're getting criminally charged for things that happen at work. This has once again happened. It's a nurse this time in Ohio. A ton of you sent this to me. So I thought I would recruit the members of the panel and we could discuss it. We have Mr. Midwife. We have Lorie, who's a lawyer. Perfect. We have Scott. And I think, Adriane, other people might pop in, but we're going to discuss it today. Basically, we'll give you a rundown of what the case is and then discuss if you're unfamiliar. So a lot of nurses, this is just a weird situation, right? When we start charging nurses criminally for things that happen as accident at work, right? And before we even start talking about this, I do want to say, this is a horrible thing that happened to this patient. It's not like any of us are saying that it's okay that this happened. I think we should be able to have a conversation on both sides of on one side, this is really sad that this happened to this person. They should not have passed away that they did. And it was really horrible, while also evaluating, but are the repercussions of this really appropriate for what happened? Because as humans, we make mistakes, right? And this was, depending on the type of job that you do, your mistake is going to cause waves in very different ways, right? So when I was a waitress, if I made a mistake, the stakes were pretty low, right? When I became a nurse, if I made a mistake, the stakes are now going to be much higher. So I think we have to really critically look at, why are all these nurses getting criminally charged with these things? Criminally being more, that this person is doing a crime, meant to do it, versus just civil, hey, this happened, it really shouldn't, let's maybe do a monetary penalty or something. And it's just, I don't know, it's just kind of a mess. It's giving a lot of, don't love it. Hello, panel people. How are we today? After that lovely introduction.
We're good. It's going to be 80 degrees here today, so I'm going to shed this shirt here shortly, I think.
Oh my gosh. I can't wait for March to be done. I feel like we're in just never-ending winter because I live in the cold place. So
this is when another atmospheric river blowing through Central California. So it's raining cats, but we were in a drought, so we needed the water, just not all at one time. But it does kind of rinse the city off, and sometimes it needs San Francisco needs to be hosed off every once in a while. So this works for that, and it's nice afterwards.
I feel like our healthcare system needs to be hosed off. Just kind of wash it off and be like, let's just start. We got a lot going on. Let's just stop and start again. Oh my goodness. So yes, and just send good vibes to everyone who's stuck in never-ending winter of the rest of the country that's cold, because I need it to be sunny and not so windy and so cold. It's snowing right now at my house, and I'm not here for it. Okay, let us pull this up. Oh, where'd it go? There we go. Okay, so this is the case. Let me know in the chat if you've heard of this or if this is new to you. It's, I don't know, mildly alarming, I think, how many of these criminal cases now that we're seeing involving healthcare people. But here we go. A former nurse at an Ohio nursing home has been sentenced to 3 years of probation and ordered to surrender their nursing license in connection with a patient's death that occurred last May. And just as a general FYI, your nursing license that's its own separate thing when it gets taken away. There's in most states, you would kind of go, and it's almost like your own little trial, right? When you have your nursing license, you go before your nursing board and they decide if they're going to revoke your nursing license. So it's a fun extra thing, just so you know, that can happen in your life. The legal system usually doesn't take away your nursing license. I mean, it might in Ohio, but at least where I live, it would be, you would go before a board of people, the nursing board, and they would kind of vote. Lorie, is that kind of your understanding of it in most places?
Well, there's 3 types of law. There is administrative, which is nursing board matters. Okay. There's criminal, which can take your freedom. And then there's civil. So this case actually encompasses all 3. There is a medical malpractice complaint pending because it is civil. Mm-hmm. And then the criminal matter against the nurse. But the judge actually sentenced the nurse to never practice nursing again, as a volunteer or not. The judge just skipped the nursing board and said, we're going to handle this without the nursing board. So And actually, I looked her license up, and it is still active, which is interesting.
Oh, interesting. So they haven't even handled it on the nursing board side yet.
Right.
What a mess.
Lorie, can a judge do that? Can a judge who is in a criminal or civil matter, can he or she make a decision that affects administrative law, like a license?
Yeah, I've seen this a couple of times, but not very often. And what's interesting is Redonda Vaught, even though she was convicted criminally and went to a hearing before the nursing board and lost her license, she is now appealing that decision to get that back. And she has oral arguments on March 28th.
Brave human.
Yes.
Brave human.
Very brief.
I'm not sure I would want back in after all of that, but I mean,
No.
obviously she gets to decide whatever she wants to do.
Good for her though, because the first round with that board, they said everything was fine, right? And then they retracted everything. So I think what the opportunity for her there is to expose some of the backsliding, and I don't know what we call it, I'm losing my terms, but everybody who changed their minds and changed their stories in that food chain of authority, the CEO, the medical examiner, all the members of the board, who really never faced any responsibility for their part in that whole situation. And why did they retract and change all their stories? I mean, to change a medical examiner report is pretty, I don't want to use that word, but you know what I'm saying? I mean, it's pretty daring, right? So I think perhaps it's an opportunity, but again, I'm surprised, but I'm happy for her. I'm happy for her good on her for doing it.
Yeah, well, that's what she wants to do.
But
there's an opportunity for a lot to be. There's an opportunity for a lot to be exposed and to come out as a result of that process. So even if you just go think about and Lorie, maybe you can help explain it a little better. Just going through that process, there may be things that she can bring forward that then can be spoken about later, no matter what the outcome.
Yeah, she actually did have a hearing before the nursing board that revoked it, and judicial review for administrative law is very difficult. You have to show that the administrative agency was arbitrary and capricious in their decision. And so it's really just a paper review, although they are going to host oral arguments on March 28th. But the judge has to determine if the board was arbitrary and capricious in their decision before it even gets sent back to the board for another hearing. And it's a very tough hurdle. It's like the highest standard to cross.
Ugh.
So Miss Mellon made a comment. There's a nursing shortage. There's a shortage of nurses who work at the bedside, and I'm just going to interject here. This is why. It's things like this that make nurses not want to return to the bedside.
Yeah, for sure. If you feel like you're going to make a mistake at work and then get criminally charged on it, I mean, that would definitely make anyone, I think again, because at least when I was a nurse, that's not what I was worried about. When I was doing bedside stuff, I worried like I could lose my license if I do something purposefully negligent, was in my mind what I was worried about. Like if I do something that I am, going into this and really making an oops, and it's something that a reasonable human would not do, or, like a civil charge, more of when I was a nurse practitioner. Like if I did something and I really big oopsed, that's more what I never even really crossed my mind until we looked at the whole Redonda Vaught thing, which we've done a bunch of videos on that. If you want to go learn more about what that situation was, I'll link them after this video. It never even crossed my mind that you could get criminally charged if I was not going into it with bad intent. You know what I mean? That just didn't even cross my mind. And
that's what I was going to say. I don't think that's why, with all due respect, Chad, I don't think that's the main reason why there aren't nurses at the bedside. They're afraid of being charged criminally. I think there are a lot of day-to-day things, like problems with support, not having staffing being a huge one, and not having support from management, things like that. And then you add on something like this, which really just started last year, right, with Redonda. In her case, that it's whoa, wait, now we're going to add criminal charges on top, because we've always been nervous, and rightly so, about not doing anything to lose our licenses. But then this was new. It's criminal charges that was added on a little later. So I think it's one more thing that might prevent people from wanting to work bedside. Plus, it's hard work. And it pays well in most cases, so there's that. You get benefits if you're full time, but then it's hard. There's it's hard.
Yeah. Well, and it piles onto a whole already pile of poo, right? Because you're like, well, we don't have enough enough ratios. So there's not enough nurses for patients. So things are risky already. We're not well staffed. I'm working a bajillion days in a row. And now, so I'm more likely to make an error because we know for every nurse you add, you are, I forget even what the percentage is. You're a certain percent, like something like 7 to 10% more likely to make an error that could be fatal for every patient you add. And then if this is how we're going to treat people who do make errors, right? It just it doesn't help in any way, shape, or form. Our end patient said 100% this case made me rethink whether or not I wanted to work bedside, to suffer through everything else. And then on top of that, constantly come home and wonder if I did something that was going to be charged. Yeah, that's just it's not a good day.
And that was my point.
I would say it's it. Okay.
I don't know how many people remember. I was kind of a lone voice, or at least I felt like I was a lone voice in that whole thing, because I didn't believe that Redondo deserved the benefit of the doubt. In a lot of cases, there are a lot of things that contribute to an error. In this case, I looked into it, I did my research, and everything I saw said it was her. She just made mistake after mistake, and unfortunately someone died. I don't necessarily think criminal charges were the answer, but my point what became my point in that conversation is nurses going around with their hair on fire, talking about nobody's going to want to be a nurse, and nurses will leave the bedside because of this. And I'm like, well, yeah, if you keep screaming about it like that, this is actually an opportunity for nurses to say, hey, you know what, public, you trust us. It's been shown year after year in those polls. And we want to tell you that trust is not misplaced. Yeah, we have a bad apple. We have our standards, we have our rules, and we took her license away because she doesn't meet our standards. We are still committed to patient care. You can still trust us. It was an opportunity for us to say that. And people who are nurses, we tell them, look, this is the exception, not the rule. We don't have nurses. Now it seems like we hear about it more often, but for the thousands of, well, I guess millions of nurses in the country, we a handful have been charged criminally, and not capriciously, not because they, skipped a medication at, 7 a.m. It's because something really big happened. It's an opportunity to kind of reassure the public and reassure potential nurses and current nurses that your license is safe as long as you practice safely. And there are examples of people who lose their license clearly, and maybe some of them didn't deserve to lose them. But I thought there was an opportunity wasted with the whole conversation about Redondo Vaught, that we were scaring each other and the public unnecessarily.
I don't know. I'm glad you're optimistic. I feel like it's happening way too often, and it's unnerving.
Come on out of California.
Yeah.
See what the rest of the world's like.
No, this
it's
isn't
totally fine to
I realize that being in California, we have ratios, and so the work is sometimes easier. I recognize we've had a lot of discussions. I've learned a lot about how it's different here, but I'm just talking about in general, losing your license, operating safe, working not negligently, safely, working safely, practicing safely, and the fear of actually being charged criminally. I think it was blown out of proportion. I'm not saying it's zero, clearly, but I'm saying I think it was blown out of proportion and unnecessarily scaring some people that really should be at the bedside and helping us out.
And that's why we have you here, for our voice of optimism, because I think it's ridiculous how, especially with this case. So we'll look at it and we'll see how you feel, because I don't know. I feel like there are more and more things that are coming out like this, where people are getting totally just they're plucking out a mistake that anyone without any ill intent could make, a very reasonable mistake, and they're getting criminally charged for it. So with this patient, it was in May of 2021, a nurse at Capri Gardens. It was a nursing and rehab center in Lewis, Ohio. She removed the tracheostomy mask. So if you aren't familiar, it's this person had an artificial airway. So they probably had something in their neck, going down into their lungs. It was breathing for them. So they either had that. I don't know if it was mechanical ventilation. I don't know what exactly they had, but they were getting oxygen through it. So the oxygen is very important. It got gross, whether for whatever reason. They took it off to clean it, because they get gross all the time, right? That's trach care, something you do all the time as a nurse. Let's clean the area. Let's clean the mask. Maybe you coughed up a bunch of secretions into the thing and you have to clean it. Took it off to clean it. And usually the person is okay during that, right? Because it's usually a quick fix that they're doing it. forgot to put the oxygen mask back on. Okay. And the patient passed away. Now that is a horrible, horrible way to pass away from the patient. Again, not taking away from like, should this have happened? No. But this person, due to the type of job that they do, made a mistake and didn't put the oxygen mask back on for whatever reason, right? She made a mistake and now she's getting charged with, she got 2 different charges, but they ended up going with involuntary manslaughter, which we can look at what that means in Ohio. But I don't think that was intentional. You know what I mean? Like it's obviously awful, but to get criminal charges for it just seems like.
This came up in the Redonda case too, and I'll defer to the lawyer on the panel, but you don't have to have intent for it to be a crime. There's something called negligence, where you absolutely don't intend to do it, but you should have known better. You had a responsibility. You breached that responsibility. How am I doing, lawyer? Am I close?
Yes, exactly. It's like somebody drunk driving. They didn't intend to kill the person that they hit, but they did. And so the law has to have a basis to take action against them. But I don't think the law, this negligent homicide, was ever meant for nurses or healthcare providers. And I think what bothers me the most is, like here in both this case and in Redonda's Vaught's case, they were just doing their job, albeit negligently. They were just doing their job. And so why should it rise to the level of a criminal matter? And that's what boggles me about all of this.
Well, why wouldn't it? If you do something if you had a responsibility to someone and you didn't live up to that and they died, why is the fact that you were on the clock make that not a crime?
Because I think a lot of other things play into it. Such as poor staffing, or in Redonda's case, there were so many contributing factors to it. Yeah, she was the ultimate, person at the end who didn't look and gave it.
We'll agree to disagree on that on Redonda, but yeah, you're right. In many cases, it's several mistakes in a row, or I'm thinking of what was her name? The OB nurse, Julie Thoreau, that mixed up the two bottles. One was antibiotic IV. The other was, I think, like Marcaine for the epidural. And she mixed them up, and the patient died. The baby survived, by the way. But in that case, that was a mistake I could have made. You look at the pictures of these bottles. One had an orange sticker, one had a yellow sticker, same tubing. So in that case, it's like, yeah, the nurse made a mistake, but it really was a mistake any of us could make. Redonda pulled the wrong med. She didn't read the vial. She reconstituted it. The drug she was supposed to have didn't need to be reconstituted. She gave it. She walked away. Had she stayed there and said, "Are you feeling better?" they could have resuscitated that woman right away. There's mistake after mistake. So we'll agree to disagree on that. But you're right that oftentimes there are all kinds of contributing factors that have to be taken.
Yeah. The point is, none of these accidents or mistakes happen in a vacuum. It's always, every single time, a series of unfortunate events. This stacked on this, and it has a domino effect until somebody dies.
But not always. Sometimes you have someone who just screwed up. Sometimes you have someone like Redonda that just messed up. She made mistake after mistake. Who knows why? And
but with Redonda's case, if there had been policies in place to have a monitored patient, that patient should have been on the monitor. So if there was policies in place to have that patient on a pulse ox, on a telemetry monitor, in the MRI or CAT scan, I can't remember which it was, right? Then those policies, that is why those policies are in place. Because I know my hospital used to just send patients all over for procedures off tele. And we were like, well, if there's a tele order, why isn't the tele order mean they have to be on tele 24/7, but they can go down to MRI and be down there for 3 hours, or, a VQ scan, or these long exams, right? And so we put enough pressure on the hospital around this as a safety issue to make them have a nurse go with the patient on a portable Zoll, which then they didn't even have pulse oxes on the Zolls. But then there was examples of patients having to go to radiation therapy, where there was no way to monitor those patients. We had this little tiny camera and a little tiny screen, and if something happened, they're locked in, the vault. There was nothing we could really do. So again, those are breakdowns of policy and safety protocols that then can be easily put on a nurse for, oh, well, you were there to monitor. Why didn't you do something? That patient coded. But, it's so if there's if the thing is, you have to ask yourself, is it possible that there could have been policies or procedures that would have been a safety net for the result? That's all.
I don't disagree with that there can be better safety precautions, but again, going back, I know we're not really discussing the Vought case, but we are. It was entirely possible to give safe care with the rules that were in place. It's not like,
that's always the case. But that's always the case.
Right. It's possible to give safe care even with the precautions that were in place, like having a Pyxis that you had to take it out of instead of just on a shelf. You know, whatever was in place, it was entirely possible for her to do what she did and do it safely, but she didn't. And I don't, you know, there's not a lot of contributing factors like there was in the OB nurse case where it was so easy to make that mistake.
But I think there's a difference between, like, you know, willful negligence or willful, like, you know, a NICU nurse banging a baby around and somebody punching a patient in the skilled nursing facility versus mistakes that can happen that where you have a system that you're working in or an environment, right? It's like, you know, plenty of people got in car accidents before seatbelts and didn't die. They were totally safe. So does that mean we didn't need seatbelts, right? So it's, again, those were safety measures that are put into place that alter outcomes. And so if there's safety measures that can be put into place that could possibly alter outcomes and policy, and, you know, and again, because I've been involved so much with hospital policy, there's so many places that policies can help save people. So, you know, it's something that we have to think about. But I do know that as far as nurses leaving the bedside, especially in long-term care, there's long-term care facilities where I'm at that are offering like $20,000 sign-on bonuses, right? Even though it's still low pay, but you're like, it doesn't matter because nothing is worth me having 50 patients and having to run off because you don't know if a patient's coded. You don't know if somebody fell. You don't know if that nurse just got distracted. I mean, I did vents for 12 years. This patient was, I think, on aerosolized air. So, you know, it wasn't a ventilator situation as far as I know. I put a link in the chat with what I think the thing looked like, the mask. So, you know, it's just you have to work very hard to not have a liability. And that's the whole issue here with nurses saying it's not worth it because you get one license. So why not leave and just do your own thing? You know, if I got one license I'm going to have, it's not worth it to put your license at risk working for an employer that's going to actually be placing your license at risk through their own willful negligence of not having enough staff, not having correct policies in place, not having good, you know, labor practices, all of that, you know.
Well, you know, policies, procedures only takes us so far. And siding with Scott here, you've got policies and procedures and rules and regulations, but ultimately it comes down to common sense. I have never in my life given any medication and then walked away. I always stand by for 2 or 3 minutes, make sure everything is okay, chit chat with the patient for a minute as it starts running in, whatever else, and then I walk away. There's a level of common sense that has to be incorporated into everything we do. And
I've never given 100%. A medication without reading the label on the bottle. I do. I give myself injections once every 2 weeks. I still read the bottle when I pull up the medication. It's just habit. It's like, that is what I think it is, right? Yeah. Okay. It's just a thing. Liz, I put a thing if you want to add it that shows what the mask looks like, what I think we're talking about. It's at the bottom with all the rest of us. So I don't think it doesn't sound like the patient was ventilated and dependent on a machine to breathe, but it was giving oxygen to someone. It's like the little tube under your nose for people that don't, that don't have a vent. Mm-hmm. It's just a way of blowing oxygen into their airway so that they have it available. I don't think it was breathing for her though, just to be clear.
No, that's what this is what I imagined was just the collar.
Yeah. My sense is that, well, first off, if somebody's on, this is you can do high flow in those, but if it wasn't high flow, who knows, and I don't know what all the regs are for long-term care and all that, but in this kind of facility, but it takes a while to get to the point to deoxygenate to where you're going to pass. So these nurses have 50 patients. They've got giant facilities. I taught CNAs, so I worked on the weekends teaching clinicals, and it was a complete crap show because half the staff wouldn't even show up. because they were working other jobs till 7 a.m. when the shift started at 6, and we would show up there with students and we were like, there was nobody there. I mean, and that's California, right? So, I mean, I just think anything that happens in a skilled nursing facility, anything's possible. It is a complete free for all. And you're taking, your loved ones' lives in your hands. You're taking your license in your hand. I mean, it's just a horrible situation. There are no good ones unless you're private paying.
That's a good point. KM Shannon says, how did they know that's what killed her? It could have been coincidental that an old patient in fragile health would have died that day anyway.
It could be, but
I don't know.
I think the bigger thing is just why are we criminally, like, just going back to why are we treating people who make a legitimate mistake, which is awful, right? Like a legitimate mistake are now being treated criminally. And if you look at, I was looking up all the other cases of Ohio nurses that have recently been criminally charged. And it's like it's either things like this, right? So half of them seemed like they were this. You made a legitimate mistake. You did this. You gave a wrong med. And the other half are you were on meth and you were the overnight nurse for someone and something happened to them and you didn't know because you were high. I'm like, those are not the same. Okay. You going in and forgetting to rehook up an oxygen thing for whatever reason, I don't think you did. Like any of us could have made that mistake, right? Where you just literally skipped one very important step, understandably, and then didn't get to go back in because you have however many other nurses versus you going to your work, like, and doing meth. Like those are not the same things, you know what I mean? But they're being treated. Those are the two criminal charges that we're seeing. And it's like, why are we going after people who are making an error at their job because they are human and they made a mistake? Like the same way we're doing that. Or like Lorie said, like in Ohio, this charge is the same charge as you would give someone to a slightly lesser degree. I mean, it's in the same family as if they were drunk driving. So in Ohio, involuntary manslaughter, they got the 3rd degree felony, which basically means that they were not they were committing a misdemeanor when they did it. I don't know what misdemeanor they're charging her with. But this is this is the DUI thing. And I think it's different from going to get in your car when you're intoxicated and making that choice. Like that's how they're charging these people who made a mistake at their job. And it just makes no sense to me whatsoever.
Well, and I think we also have to look at the other component here is, being from a union background, we always would say, are the rules being applied equally? So it's the same thing. Are the laws being applied equally as far as with doctors, with providers? Mm-hmm. Heck no, they're not. We all know that. They get away with so much, right? I mean, medical errors, procedural errors, all kinds of things. If we're going to go after and start doing this, then, then what about all the providers that make mistakes at the bedside? What about, or procedural areas, the surgery mess ups that nobody knows about? I mean, look, OR nurses are the secret, the holders of many secrets of many, many errors that happen in surgery. And it's, that they do not speak about it because they're afraid of retribution. And these are things you'll never be able to even find in a chart because they're not documented, right? So again, I think that's the other big elephant in the room. It's like we are focusing on a profession versus the system. And then we're allowing another group of individuals who commit far greater number of errors resulting in death to completely walk, unless it's incredibly egregious, unless they're basically a serial killer, right? Mm-hmm. So that's the problem, right? It's like, why are we focusing on LPNs and RNs and not not at another level here, right?
Because you're right. It's not happening up the chain and then like hospitals don't, people don't even want to investigate that because it's.
And then it's just like anything else, right? So why are we not going up that food chain and making those administrators responsible? Why are we not making those owners responsible? Why are we not making those private equity companies that have bought up medical practices and skilled nursing facilities responsible, right? I mean, there's a lot of money going on in the back end here that has a lot to do, I believe personally, with why RNs and LPNs are being charged versus anybody else in these systems, right? And your doctor could order in a sniff the completely wrong wound care treatment, right? But that nurse is going to be charged if the patient applies it and then gets an infection and then dies. There's a problem. There's a problem in the system, and it has to do with money. It has to do with who's owning these systems, hedge fund, private equity hedge funds, and the massive amount of money that they have infused into lobbying as well. They've managed to deflect things and now get the courts to go on this prosecutorial, bend, and at the bottom end of the chain, not going up to the top end to actually make change.
Yeah. And I have what the governor or attorney general said about it, just because I was curious why they were going after it so hard. Like, what is motivating this? And they were a quote from the Delaware County prosecuting attorney, Michelle Schiffel, and her office was the one that actually prosecuted the case, said, "Our office will never hesitate to fight for those who are victimized or those who victimize the most vulnerable in our population. We're thankful for our law enforcement partners who investigated this tragic crime." And I just thought that was a dumb way to phrase it, because I don't think this person was trying to victimize a person in a vulnerable population. Like the first person up here, this is a good counter to it. So in this press release, they were talking about two different nurses who were charged. The first one stole millions of dollars from people in insurance fraud scams. Like clearly that human went into work and was like, "I'm going to be the villain today. Let's do it." The second person made an error, and I don't think they were going into to victimize this person who was in a vulnerable situation. The Attorney General, their whole stance on it was that we always advocate for our most vulnerable populations, especially in the care of elderly and others. And this dude, the Attorney General in general of Ohio, his platform is protecting the unprotected, is his slogan that he's going with right now. So I don't know if that has anything to do with what they're going into, why they're doing this, or who knows why they're doing it. But I thought that was just interesting that's how they were choosing to frame it, making it seem very much like this person went in to go and do something evil. And I get how it can seem like that if you don't normally do things like this, which is why we're talking about it. So kind of in line with this question, but how did the nurse forget to hook up the oxygen component? You clean up the equipment and then reattach the equipment. That's how I was taught to do trach care. And that's how you were taught to do trach care in a perfect vacuum, where you didn't have 30 other patients, where you didn't have 50 million things going on, call bells going off, people calling. When you're taught to do trach care, it's a one-on-one environment. The world is perfect. You don't even have other real patients. You're there with your one instructor who's guiding you the whole time. You are in a bubble of perfection that does not exist in real life. In real life, you have people yelling down the hall, screaming, doing whatever. You have to go do 20 other tasks. You probably haven't gotten lunch that day. Who knows how long you've been working? You're exhausted. It is not, you don't exist in a vacuum, and that's how mistakes get made, right? I don't think this person went into work that day and said, "I'm going to make a stupid mistake that's going to end my career and land me with criminal charges." That's not what happened here. I don't know. It really makes me very mad.
I guess the real question is, and we all agree that person didn't go in that day saying, which patient am I going to kill? We all agree this was a mistake. It was an accident. And just for the record, I think this is a stupid reason to bring criminal charges against somebody. As much as I was supporting Redonda Vaught in a way, not disagreeing with bringing criminal charges, she didn't need to be criminally charged either. But this certainly is a stupid reason to do that. I think the question is, because the person made a mistake. The question really is this mistake rise to the level of negligence, of criminal negligence, or was it an honest mistake? Is it one anyone could have made? Is that, I think, is where we might disagree. I don't know.
And then are we going to start applying it across the board? Does anyone who has a job that has people's lives in its hands, do they have to be because it shouldn't just be nurses then. This should be doctors. It should be nurse practitioners. It should be police officers. It should be anyone who has the power over someone else's life. And it's not. We're not seeing childcare people. We're not seeing it being equally doled out in most of these cases.
Maybe the flip side of the coin, they hold nurses to such high esteem. We're always number one on the trust list that when we screw up, we're the ones that they go after. Just saying it's not fair, but that may be an explanation.
Liz, can you put that sentence up that I sent you?
Oh, yes. I made a banner for it.
So this is how easy it is to make a mistake. So see the banner at the bottom of the screen. I want you to count the number of the letter F's in that sentence. Count the number of F's and just put it in the chat how many you get.
This is a good debrief moment for me. I'm like, I need to calm down and count.
Here's the count. Okay. Okay, Adriane got 2, Crystal 3. What else?
3 F's.
For the record, I could do this like 10 times in a row and I would always get it wrong because I have another exercise I do for my trainees and I always get it wrong.
Yep, I just immediately got it wrong. I changed my answer.
2. Liz has 2 now, 3. Okay. But we've got 6s, 5s, 3s, 2s, you name it. So how many? So we're all intelligent people. We're all educated people. How can we all get different numbers? Scott, what's yours, by the way?
6.
6. Okay. And that is the correct answer. There are actually 6 F's in the sentence, but our brain interprets the ofs as V's. So we miss them. And so that's how easy it is. Look at Adriane. That's how easy it is to make a mistake. And I know that when Radhonda Vought's holding this vecuronium, she's reading Versed and really thinks it's Versed. And again, it's just so easy to make a mistake because our brain is filtering things for us. And so it is crazy that there really are 6 F's, but that's, again, how easy it is to make a mistake and how easy it is to forget to put a trait color back on, or how easy it is to give the wrong medication. So this is just a little simple example, but it is very demonstrative about Scott's cheating.
No.
Scott has a very good brain.
about just
you know what I was thinking? I'm visual, so I'm looking at the actual F's. I'm not thinking of the. I'm actually looking at the shape of the letters. I disagree with something you just said, but I'm going to try to back it up. Liz, I put a thing there to share as well. This is what Radhonda Vaught had to inject saline into to mix the medication to give to the patient. And I don't think it's something that she could have ignored as easily. I know you think, oh, it's Versed. Yeah, Versed. Yeah, Viva, whatever. Do you see it, Liz?
I see it. I just think, I don't know. I don't know if I want to go down all of this whole rabbit hole and rehash that entire thing today. Well, I don't know if I have it in my soul, but I like the point. This is what it looked like, just for if you are curious.
So that's the stopper she had to inject into. So if you can inject into that and not read big red letters, then maybe you have a defense for Radhonda. I didn't understand that kind of thinking. So
I just think about all the times I put, like, you know, the cereal in the fridge and the milk in the cabinet and or the dog food in the freezer. And you know, where it's just like so many things are going on. There's just only so much I can bring into my consciousness. And I'm not talking about Radhonda. I'm talking about especially in long-term care. Again, my mother lived in a long-term care facility and for 9 years of her life and was in and out of them throughout my childhood. So I spent a lot of time in these facilities as a child, as an adult, all the way to when she passed, when she was 34. And so I have seen the best, the worst, all of it in between. And that's in California. And that's me basically bribing people to take care of her. That's me spending like $1,000 a month on buying staff food, buying her food, having supplemental care, paying for private PT, private OT, you know, you name it, banquets for the staff, right? It's like stuff still happens. Things still happen because it does. It's people are busy, they're distracted. And then you do throw in people who don't really care, right? Or they're not invested because the environment, right? You're working in a cattle call kind of environment where there's not, it's just like, it's a little bit, and if the public doesn't understand this, it's just one level above prison as far as like the level of transparency of what the public sees. Nobody sees what's going on inside these facilities, you know, and other types of facilities like this. So this in turn makes the families very hypervigilant who are involved, but then when there's not families involved, a lot of things happen. I mean, my mom had a lot of friends. She lived in a senior housing, and through the years that she was in the skilled nursing facility, a lot of people who she had lived were her neighbors came into the same facility, and she would say, oh, go check on them, because they were people that didn't have any family, for whatever reason. And, it was like I was case managing all these people that really were not being treated very well, or not as optimal as my mother was, for sure. And so it just, honestly, that's why you have to have an advocate of some kind. Hey, J. Michael.
Hello, everyone.
Any thoughts?
So the one thing I wanted to mention about this, so I used to be for a short period, a director of nursing in a long-term care facility. The one thing to remember with staffing is that it's completely different than any other facility where we do staffing, where it's 5 patients to 1 nurse, 6 patients to 1 nurse. When they calculate staffing in the skilled nursing facility, staffing is based on direct care hours provided per patient. In the state of Ohio, because I looked it up, it's 2.5 hours of direct care. Now, how do they figure out how that is 2.5 hours? You add all your CNAs, all your LPNs, and all your nurses. You divide that number of hours those people are working that 24-hour period into the number of residents you have, and it needs to be 2.5 and higher. And some facilities, like I was talking to Jazzy in the chat, who's also a current DON, her facility doesn't count their quality assurance RN or their MDNP RN, which is the part of their nurses who actually send the stuff to Medicare. However, in Ohio, the policy is that those do count for your people, for your ratio.
For in terms of like staffing stuff, right? So hey, okay. So what do you think of in terms of like that being, I guess, attributed to, I guess, are you saying like the facility should be held responsible for failing to staff it appropriately because they're being sued too?
Well, I just wanted to point out that's how staffing works in the skilled nursing facilities, because it's not a clear-cut case as it would be in the others. Because, and it's not even like an RN counts for 1 hour, CNA only counts for half because they can't do as much. It's all staff. They just look at the number of nursing staff. So it's equal to. With this case, I looked at it and I think this is a big problem that's going on right now. You're having a lot of cases that are breaching the criminal when it's not criminal at all. Mm-hmm. And I don't know if it's because of the environment of blame that's going on and everything in America right now, that it seems like someone has to be responsible criminally for something. Not everything is a criminal wrong. That is why we have administrative law, that we can go, do things that are punitive to the person's license, but not to their liberty. It's totally different where there's something where it's completely a matter of intentional wrongdoing, like the individual who works outside their scope of practice, performs a technical surgery, hides the fact, and is charged. Okay, that's criminal. You're a nurse. Yeah. You're not.
There's obviously nefarious stuff going on there. Yeah.
Or if you purposely bypass multiple safeguards, I can see mechanisms in that where it could cross into the criminal, because each time you bypass and do an override is a purposeful, objective action and decision to go around the rules that are put in place. So, but if it's a simple matter where it's like just an issue, it's, you know, I don't think it's criminal at all.
No, I don't either. I think, and it's just.
And I'm sorry
ridiculous.
for the background noise. Someone's currently on vacation outside the continental United States, and there's an 8-year-old little brat sitting next to him watching videos because we just got back from swimming with turtles. Fabulous.
We're all a little bit jealous and definitely not angry at the snow outside.
Nurse March Ohio put in the chat, and she's on TikTok as well, about $6 million going into these facilities, right? Or to the lobbying and the lobbying arms, right? So again, $6 million is not a small amount of money. Nope. But again, I personally believe this is just easy pickings for these DAs to get publicity, because guess what? The DAs don't have a lot to rave about, right? They're not really prosecuting a whole lot of crime. They're not always being so successful. And these are stories that are unique. They get a lot of press. They get them a lot of traction. And it's not, you know, because they're not out there solving who's trafficking children. They're not out there prosecuting, you know, a lot of real criminals, right? And so these are just easy pickings where you don't even really need the police to do any work, right? So again, think about the kind of cases that these are versus like what we would say are like real crime happening. And then look at those DAs, look at their track record, look at these cities. You're just not going to, this is easy pickings, and it's great publicity for them because DAs are elected.
You know, and like you said, if you look at the current legal environment in the United States, this is also coming on the heels of the Alex Murdock trial, where you had a state attorney general's office do a major case, get national attention, and now you have these other AG offices in the other states. How can we get some of that good publicity for our office? Because I don't care if you're a public servant or not, publicity is what matters, and especially if you're coming up on a re-election year. So a lot of them might be a little jealous, like right now with Hayden Waters and the team over in South Carolina, because it's their heyday right now, and they want some of that, and that just happened. So how much of that plays into this? Because not everything happens in a vacuum, like you guys say.
Right. Oh, the Murdock case has so much. There's so much room for appeal in that case. One of the jurors was a brother of one of the police officers. There was Sleepzilla, the other juror who fell asleep without the blanket, right? There's so much room for appeal. That's going to be very interesting, that case.
I was going to say, as we think about activism and the things that we can do to improve healthcare, and this may seem like I'm contradicting myself, but to go and bring some attention to the DAs and say, hey, why are you going after nurses when you don't have to? Now, when in some cases, like I've said, I still say in some cases that you can't argue with some of them, but in this case, and many like it, what are you doing? And to bring light to that and bring that to not shame them exactly, but call them on it, and you know, be in the spot. If they want the spotlight on them, jump in the spotlight with them and go, yeah, good for you. Why are you doing this to nurses? And hopefully the public will be on our side as they have been in the past. I don't know. Something to think about. Another letter to write. Another angry letter we could write.
Yeah, the prosecutor has discretion as to whether or not to bring criminal charges. And the fact that they are bringing them, you know, the public needs to say, well, wait a minute, you know, this is malpractice. This is not a criminal matter. Yeah, somebody did pass away. It's really unfortunate, but, you know, it's malpractice. And that's where I think it belongs.
Yeah. Is this what
and two, was the case brought before the state board, and did the state board in their process recommend proffering of criminal charges? I think that should actually be part of the process, where, you know, if it is a matter that is criminal, that it needs to go first to the state board, and where they could, as part of their process, recommend the proffering of charges. You know, to me, that would have more backbone to it, where you have, nurses saying, okay, because you have that whole thing of reasonableness. Would a reasonable nurse feel that this is XYZ? That would answer that question if you have a board of nurses saying, hey, this is criminal, proper charges,
But then we need to have more oversight into the board of nursing, because that's kind of like a wild free for all of like, I don't even know how you really got there. And you have a lot of weird power and not a lot of oversight. But I mean, I like that
they're
idea.
Not elected or anything like that. Because I don't even know, are they even confirmed by the science?
No.
I think they
self-appointed.
We don't really
They're
know.
self-appointed.
Usually
They're
by
there.
the governor. But
Before you said that, I had an idea. Maybe that's an idea for legislation, that any criminal case charging a nurse based on actions that happened when that nurse was on the job should require testimony from the board of nursing. Not on either one's behalf, but just like as an expert, they have to weigh in on that criminal case in court. I don't know if that's...
That's an interesting mechanism of doing that.
Yeah, the burden of proof is very different for the civil case, for the administrative case, and for the criminal case, whereas the criminal is the most strict.
Mm-hmm.
It's beyond a reasonable doubt.
Mm-hmm. And she pled in this case. She actually, so she was never she didn't go before a trial or anything like that. She said, I pled guilty, and then it sounds like they took off the reckless homicide charge, which I thought was interesting, because that seems like it would have fit more what she did versus the other, but obviously not a lawyer. But they did that. And then they're also going after the facility. So it's kind of like a double whammy. The wife of the patient, the state decided to put these charges against her. And then the wife is charging the facility with a wrongful death suit, which is totally different. And they're going to announce that this month. But is there anything, Lorie, that so you can't, correct me if I'm wrong, you can't be covered under malpractice for criminal charges, correct?
Right.
So there's really nothing you can do as a nurse other than never make a mistake.
Right.
And don't do it publicly.
Yeah. For Redonda, they raised $150,000 for her defense. So yeah, unfortunately, insurance will not cover you for criminal matters, but they will definitely cover you for professional licensing defense, things before the nursing board. And if you, they'll also cover you. You'll have your own attorney for the malpractice case. So if your interests are different than your hospital's, you're going to have your own attorney if you have your own insurance.
Mm-hmm. Okay.
And document. Is that still a good defense?
Absolutely.
Hope it doesn't get picked up. Do you have any advice for people? So Nirali and a couple other people in the chat have said different things, like how do you get over the fear of making a mistake, or what is really your option? Because eventually everyone is going to make a mistake. Looking at that, I would say the likelihood of you getting prosecuted is low, bonus, right? Because even though we're seeing a lot of these cases, we're not seeing, it's still a very small portion of the population. The crappy part is it seems to be at random sometimes, like this one. Don't go maybe and do meth and go to work, but that's with a little bit more, validity. Or don't go and, do insurance schemes and get millions of dollars from your patients. Also bad choice. But I don't know. That's the hard part of it, is it's kind of in the back of your mind, go to med school maybe, because they don't seem to be getting criminally charged nearly as often. So that's another option.
Well, as driving a car and being a new grad nurse are a little bit alike. When you first learning, you first get out there, you're nervous and you're looking and you're scared. And at some point you just melt into, you are one with the car. You don't think about it. You just do it. And being a nurse is a lot the same way. Your first year or so, you're scared to death. You're hypersensitive about everything. And at some point it's who you are. It's how you live your life. And you don't purposely go out and say, I'm going to make a mistake today. You don't purposely go out and say, I'm going to kill someone today. And you do the very best you can with every patient you have. And that's the best defense that I could suggest to anybody.
At least going into it, Nora, you accept a certain amount of risk when you go into certain jobs. If it's a dangerous job, you accept the risk you could fall off the girder building the skyscraper and fall to your death. If it's, something else, you could be exposed to chemicals, or you could hurt somebody if you're, a healthcare worker or a tattoo artist, you accept a certain amount of risk in anything that you do. It's a matter of, is this the level of risk that you're comfortable with? And Chad's right. You start out being hypervigilant, like when you're first driving a car, but it does become more routine. You do get used to having that responsibility, and you accept that respect. And if you don't, then there's probably another job that's more suited for you.
And the truth is, you accept risk getting out of bed every morning. You accept risk every time you leave the house. You accept risk every time you get behind the wheel of a car. There's just intrinsic risk. Mitigate that risk as best you can. Mm-hmm. Be cognizant of what you're doing.
Everything is a balance, right? So,
yes.
I work really hard. They're going to pay me money for it. Is the money worth how hard I work? If yes, I will take the job. There's risk involved. I could make a mistake. I could go to jail. The risk is small, but it's not zero. But the other side is I can have a very rewarding career and really help some people and make an honest living doing it. Is that worth that little risk? That's a question you have to answer for yourself. A lot of us have said yes. And some of us are changing our minds. There's people that are actually leaving the bedside and going, that risk went from this much non-zero to this much not zero. And that's enough for me to decide to do something else.
And that's okay.
And that is okay.
And that's okay. And also knowing there's so many different nursing jobs out there, right? Some of them are going to have inherently much less risk associated with them, versus you're going to have a much lower risk profile working in a primary care clinic, working as a triage nurse or a type 1 diabetes educator, right? Versus if you're Scott in the ER doing like 12 things at once, being like, let me just figure out which one of you I'm going to magically save first. Like that's a much higher risk all in all. You know what I mean? But you do really get used to it. Like I cried every day for a year.
Nora brings up a good point. She says she accepts the risk for herself, but she's mortified at the prospect of someone losing their baby because she missed something. I agree. We all agree with you there. Mm-hmm. And in that case, I would say, don't work labor and delivery. That's the simple answer to that one. I'll tell you what, though, just based on not knowing you, just knowing the world as it is, and the chances of you being criminally charged and thrown in jail for something you did at work, it's not zero, but it's small. I would bet money on you that you're not going to jail. It's a good bet. It's not zero. And you're betting with more than money. You're betting with your life, but it is very small. And it may be balanced by the rewards that you want to actually contribute to the world in this way and have this career. I feel your struggle, but it's only you can really answer that.
And there's a big difference between having a fear of having someone else's life in your hands and having healthy respect for having someone else's life in your hands. If you just go on every day with having that healthy respect, purposely trying to be cognizant of what you're doing and paying attention to your surroundings, you should be fine.
And I would add that, use your discernment in what jobs you take, because in both of these situations, Vanderbilt was a mess. They're telling nurses to override the Pyxis and some talking to the EMR system. So use your judgment. And if you not in a facility that supports you and is staffed properly, don't stay. My favorite quote by me is, you can always get another job, but not another license.
That's right.
And Nora, let me just disabuse you of the notion that you're going to be perfect. You just typed in the chat. You're not going to be perfect. You will make a mistake. It will not kill someone, most likely. It will be one of those things that you kick yourself going, what was I thinking? I meant to give this and I gave that, or I completely forgot that patient was on the toilet for 3 hours, or something is going to happen because why? You're a human being like the rest of us. Now, you try to do your best and you try to have people around you that will help catch each other's mistakes and help not cover up, but cover for each other. But get that out of your head right now, that you're going to be perfect and never make a mistake, because the first time you do, it'll be more traumatic to you than it has to be.
Mm-hmm.
And
then you'll never do it again.
We can't allow the good to be, the perfect to be the enemy of the good. Right. Sometimes good enough is right. As long as your patient is safe, you're doing the care that they need to help them get better, you can't do, that dressing change the absolute perfect textbook way. Nothing happens in the real world like it does in a textbook. And we need to do that. The problem with this situation is the scales of justice are being heavily outweighed now, that on the risk benefit analysis, that the risk now includes not only losing our license, but our liberty and freedom for actions that are simple errors outside, and they're looking at it in a vacuum. It's like there's so many other situations that could have occurred. Was there a code blue at that time? Was there a worse patient that, if they didn't react, would have died? Would they then get charged for that murder for not acting? There's so many convoluted parts to this that really changes the entire dynamic. And so I can see where people are afraid, because that balancing act between risk benefit analysis is heavily skewed right now to the risk side if they're changing it from a licensure matter to a matter of it's now up to your liberty.
Yeah.
All you can do is mitigate, the circumstance, make it less likely to make a mistake. How do you do that? Get in the habit of working slowly. Get into really good habits, like, not to blow my own horn, but I always read the vial before I give a medicine. You don't have to. I already scanned it. The computer says it's the right medicine, everything. It's just one of those things I always did. Get in the habit of doing things like that, and surround yourself with good people, like Lorie suggested. If you're not in a place that supports you, people are going to throw you under the bus. Get out of there, and fast. And a place with decent staffing so you don't feel rushed. Now, I know this is all ideal, and someone's going to make a joke in just a second about coming to California, but you can find good places to work anywhere, I know.
Well, and it's like you're saying, it's a lot of those simple actions. Like, for instance, one of the things that at my workplace that said at every huddle, you only get medications for one patient at a time. You only get insulin for one patient at a time. You go give that patient their medication, then you withdraw your medicine. Simple things like that. Like what you're saying about the medications when you scan it. It's an extra little step, but okay, this is your atorvastatin. This is for your cholesterol. This is this. It's a double check that you're also visualizing it, speaking what it's for and everything, verifying the scan, and you're also educating your patient at the same time. It's that extra little step versus just scan. Okay, no errors, change your meds. And take that extra little step.
But even how many times do we go? How many times? I have never in my entire life, going to a physician's office, a provider's office, when they do your blood pressure, they do your pulse, right, your temperature. Not a single time have I ever been told what those are, what those measurements are. In my entire life, I have never ever been told what my blood pressure is, what my pulse is, ever. So, I mean, this is like a big issue. Like, this is something that's so important in just care, right? And I did my video I did a couple weeks about this. I talked about that, and that, it's just so funny. Even though I'll say, oh yeah, I'm a nurse or whatever, it's like, and then I'll have to ask, or they'll leave the room and I'll turn the machine back on and go through the history, and then I'll pull the number, right? Because I'm at an age where things are changing a little bit. I used to be like, my heart rate used to be like 47 and my blood pressure was like 90 over 60 or 50 most of my life. Those numbers are changing a little bit. As my doctor says, that's how I approach 60. But I wanted to point out, just getting back to the story about this nurse, about this situation, when you look at this timing of it, here's another factor. This happened at 6:45 in the morning, shift change. So shift change is a very dangerous time. We also have these facilities that don't want nurses, or they're breathing down people's back about don't work overtime, get off the floor, give report. And in long-term care facilities, like 6:45, half the staff's already out the door, right? So again, now you have another staff that comes in, they say the patient's suffocated. Is that possible on just air, like on oxygen? Sure. I mean, it is, but it's the problem here is also what I'm seeing is it's shift change. So at what point after you get report, are you actually able to get around to see all of your patients I mean, does that even happen, right? Because let's just face it, it's a free-for-all. So I think that the shift change component also has a lot to do with this, right? Because that nurse probably was being stressed to get out on time. Then that nurse has got to document what she's just done. And God forbid you have 5 seconds of overtime. So that's another big issue. And this is a lot of nurses, they work for free. They do charting, right? I tell nurses all the time, don't do that. But I just wanted to point out that this happened at shift change. Very,
Well,
very
and
dangerous time.
at that
That's a good point.
time, it's not only shift change, you also have the problem that it's mealtime. And in a skilled nursing facility at mealtime, there must be a nurse in every meal room,
Mm-hmm.
not a CNA,
Right.
not a nutritionist. It must be a nurse
Which
in
is a
case
lie.
there's choking or
That
anything
doesn't
of
happen.
that. At mine, I mean, at a skilled nursing facility, it's required by law. You had to have one. It's also they're doing their morning med pass. That med pass in the nursing home is about 2.5 hours because you
Right.
have 40 patients.
They're
So you
checking
have all
blood
that.
sugars,
And
all that.
who at that time is going to be doing a trach care in the middle of all that? That's what's crazy
I think
too.
she was just cleaning out the gunk out of the mask
Yeah.
or something. I don't even know if she was doing full.
It doesn't
trach
even
care.
sound like
Right.
it was full on trach care, which is a little more
But it's
complex
just,
here.
but again, you could, the tubing could get gunked up. You might need new tubing. There's a lot of things. I mean, I did vents for 12 years. So
Yeah,
I've
if they're
seen all of it.
hacking up all sorts of stuff. Yeah.
Now, would I expect the patient to expire after an hour?
She had to be right on that edge where she was like, this happened to my dad right before he passed away. He was on oxygen on nasal cannula, which is about the same thing for someone who doesn't have a hole in their neck. This is the hole. And it was on a couple of liters of oxygen, a low setting. He was actively dying. We expected it at any time. And my mom actually said, does he really need that? I'm like, I don't know why he's on oxygen. We're waiting for him to go. And so I went ahead and turned it off. And not too long after that, he passed away. He was right at that edge where that little bit of extra oxygen was keeping him hanging on. Now, in his case, that was a good thing. It was time for him to go. In this case, maybe it was too early for this patient to go. And this patient may have even been a DNR, but that doesn't mean that this wasn't necessarily.
Well, we don't know
couldn't be prosecuted as a wrongful death.
There's a lot of factors, and that too is making me curious as the suitability of that patient truly for a SNF versus an LTAC.
Or were they on high flow? We don't know if they were on high flow or just regular. So I don't know, Lori, if you know about that. I haven't been able to find anything about.
They haven't.
There's a limit to how much you can do.
Yeah, I haven't found any.
Flow, then yeah, that patient could decompensate very quickly.
Sure.
Mm-hmm.
I mean, honestly, when you're giving a bath, I mean, like again, in this level of care, because we had an attached unit that was trach patients that were long-term care that I used to float over to. So, we'd be giving baths to patients and have them rolling them over, doing, different things. And there was some, 30 minutes, they might be off oxygen or for whatever reason, because of positioning. So it's just not impossible. The patient decompensates in 1 hour, but there's some other information here that's missing about this case, or maybe they were on high flow, but maybe they should have been in a different level of care. Again, we're putting people that are basically med-surg patients in these skilled nursing facilities, long-term care facilities, and that need a lot higher medical management. And we're not giving them any staff to do that. We're not providing laws for any kind of care.
And I think the frustration with all of that, like you guys brought up good points of like, it could have been all these other things and there could have been other things that could have gone into it that would have prevented it. And my frustration with all of that is, why are we spending our time criminally charging nurses for mistakes when we could be spending that time and energy being like, hey, this happened. So what will we learn from it? Should our patients who are on oxygen, should they be on a monitor? Like, should we have some way of knowing this? Why don't we actually do something actionable? So we're like, this is horrible. Let's make sure it never happens again, versus just like going and punitively striking down this one person who did this thing that might have like had something to do with it. You know what I mean? Is it that, this just doesn't solve anything except it ends this one person's career. And this is probably going to happen again, because we're going to get more patients at shift change who have a dirty mask, who need it to be changed, who it's not going to get put back on right. Or it could have I don't know. And you could speculate a million things. Could it have fallen off even? If you don't tie with the collars, if you don't tie the side really secure and that person shifts, the thing just comes undone and it slides right off, right? Could it have been that it was humidified air and it was sitting there, and since they didn't have, it wasn't even an oxygen component of it, right? Could it have just been humidified and then it got clogged because they required a high level of humidity? It could have been a million things, but the thing that would have solved it would have been if the patient was on a monitor, right? But they're not going to see like, how could we change these things in actual ways that would be beneficial, right? And that's what happens a lot, I feel like, in these cases, that we look at how can we blame this nurse versus how could we make a system change that keeps this from ever happening again, and use this as a learning opportunity, which is how healthcare is supposed to work, that we take awful situations and we say, what went wrong here? Like, because I bet it's going to go wrong again. And that's not happening. And that is very frustrating.
Well, and that pulls into, I think you made a really good point. It pulls into how much is this going to affect the concept of just culture in healthcare, where, we have these risk management systems that rely on nurses to make reports of situations that occur, accidents, errors, and whatnot, so that we can do a proper root cause analysis to make adjustments to policy and procedures to mitigate the risk for future. If it's going to be a situation where, if we're going to put this in the system that looks at risk management, that we're going to get charged, it's going to take those nurses who do report, because there is a just culture looking at safety, and stop them from reporting, which means that it's going to be a greater detriment to patient safety in the long run, because there isn't that just culture looking at doing things in a way to improve things overall.
Yeah. And Lorie just sent me a really great article or like the position statement from the American Association of Nurse Attorneys, kind of backing up exactly what you just said, J. Michael, which is, if you're not familiar with just culture, it's basically just that if we need to be able to admit mistakes and not have them be penalized if they were done as a true error, so that we can find the system problem that went wrong, because all errors are seen as they could have been preventable if a better system was in place. So that's kind of what that basically is. But Lorie just sent me over it. Do you want to read this? Do you want me to? I thought it was the American Association of Nurse Attorneys and their position statement on criminal prosecutions of healthcare providers of unintentional human error.
Yeah, go ahead.
So they said, in terms of this, unintentional human errors occur in clinical practice and are inevitable. The vast majority of errors reflect system problems that need to be addressed. The fear of criminal charges undermines an organization's attempt to create a culture of safety and improve those dangerous systems. The criminal prosecutions of unintentional human mistake undermines error reporting and the creation of a culture that safety undermines error reporting and the creation of a culture of safety, demoralizes providers, and accelerates the exodus from clinical practice, exacerbates the shortage of healthcare providers, contributes to a culture of blame, and perpetuates the unachievable expectations of perfection in practice. Well, they did not mince their words. They were like, here we go. Thanks for sending that over, Lorie. That
kind of sums it all up, doesn't it?
Mm-hmm.
Yeah, I wish people would use this, if they have criminal charges, because, here's an organization, I believe this one was co-written with the American Association of Legal Nurse Consultants. And again, it could help in a criminal matter.
Yeah. And this is all founded by research, right? They're able to link it back and be like, hey, look, we've done the things we've proven. Because the thing you don't want, right? And this goes back to the public safety thing. You do not want, my friends, nurses, to feel too afraid to report their errors, because I have everyone makes mistakes in their nursing career, because we are all human. And the thing we want to be able to do is to say, I did this, or I almost did this, right? In healthcare, you are encouraged to report what they call near misses, where you're like, I have done it before. I've pulled out a wrong med out of the Omnicell because I had to override it in an emergency situation. And I was at the bed, I caught it in this case, but I reported that as a near miss because I was telling the system, I could have done this. Like, I shouldn't have even been able to get to this step. And in this case, it was that you could look, it was a thing actually similar to like Redonda's thing where you could pull in, we use different names. The person who told me the med name, I was told two different, like you should use the generic or the real name. Anyway, like if we don't report those things and don't feel safe reporting them, and that we know like I can report this without getting fired or without getting sued, yikers, my friends. Like that's where the real issue falls. Not good.
Well, and then, there's an incident that happens, and like J. Michael says, we have these root cause analysis conferences, and we tear apart what actually happened or what they think happened, or try to pinpoint the problem. And then at the end of the day, they just give the nurse one more form to fill out or one more step to take, rather than going upline and saying, this problem happened in pharmacy, or it happened with a computer glitch, or it happened somewhere before it ever got to the nurse. They never do that. They never fix the upline problem. They always just give the nurse one more step to take, one more form to fill out before the treatment or the med or the whatever is given. And that's frustrating, at least to me, because as I said last week, we're telling you what's wrong. Are you going to fix it?
Yeah. And while we have a second, I forgot. Oh no, I was just going to say to go follow all of you lovely people. Irene had said that we had a good panel, and I agree. I appreciate all of you for being here. And we were able to kind of look at different sides of like everything. We're not leaving. I just realized I forgot to say to go check out all of you. I will, as soon as this is over, I'll go link everybody down in the description where you can find people's social media, or like Lorie. Lorie has her life really put together, friends. I was examining your website. I was like, well, dang, you and Adriane, look at you go. You've got like all the things. So everything, if you want to check out them, they have platforms. They're awesome. You can see them down below. Please do that, because they're what make these conversations so like well-rounded and I feel like helpful. So do go check them out. And Lorie, you had something, you are running something for nurse practitioners.
Yeah, it's just been on my heart for a while. I have two parts of my practice. One is I do professional licensing defense for nurses and other healthcare professionals. And then the other part is I empower nurses and help them start businesses. And so it's been on my heart for a while about nurse practitioners that are stuck in the term middle provider just drives me nuts. I think it's awful. And I would love to see nurse practitioners be independent and cash-based. And so I have a program coming up called Cash NP, how to create a cash NP practice without, despite what everybody else says, because, there's going to be a lot of naysayers out there, but a lot of people are doing it. And I put together a program, and I'm looking for people who are interested in being part of my beta program. And if you are, you can just go to call with Lorie, LORIE.com. It's a reduced investment for the program because I want to get great testimonials, because it's my beta program. But I'd love to see nurse practitioners be independent and not relying on corporate healthcare or insurance or any of that stuff. And you can serve the people that you want the way that you want.
Liz.
Sounds like what I need in my life. I know. But see, yes, this sounds like.
If I can rewind just a little bit to what Cal had been, Chad had been saying about the risk management thing. I think one thing that would be helpful is if we could ensure that it would stay risk management, administrative, and not criminal, and open it up to more transparency. For instance, in the skilled nursing facilities, when someone files a grievance, that's a matter of public record. Not only is it a matter of public record, you have to have a binder with all grievances filed and reactions and responses to it available for public inspection. If you don't, that is a critical strike against you by your state board. If we did something similar to that with those risk management systems in hospitals, I think that would help open the transparency level and help fix those errors at the location where it actually occurred, whether it be the pharmacy or whatnot, because I think a lot of those are hidden.
Intentionally.
I have no, I won't lie. I don't know what you're talking about because my brain went from one mode to another. I was like, wait, I'm picturing my future with Lorie. And then you went backwards. I was like, wait, what?
You're just saying that if somebody in the hospital, if a nurse says, hey, I have a near miss or something, that becomes a matter of public record and the hospital is required to respond to it. So that they can't just go,
well, like Texas,
yeah, that's great. We'll get to that.
Like Texas has
just
safe
like
harbor.
in if they file a grievance, that's the public record, and anyone can walk in and look at it.
Yeah,
I think that's a good idea.
That'll never happen.
No, but it's a good
I know
idea.
it will never happen, but I think it should.
I mean, I think it should too. I agree. I think that there should be much more transparency about, what's going on in hospitals, even down to the state licensing boards. Even in California, they protect the hospitals and facilities quite often. They used to put everything up there, details, the forms, the whole contents of an investigation. And then suddenly they weren't putting anything. They were just putting this very simple form up. And then you never really knew what happened, and so, and then they just hid behind, some BS when I would call them out on it. Like, where's the information on investigations that I was part of or that I had instigated where I knew the outcome? And I was like, you guys need to put this up. So it's very different than like dealing with Cal OSHA or OSHA, where they will put like everything out there. Like you don't have any confidence. I mean, you don't have confidentiality when you're in OSHA. Once that investigation is done, often your name may be in that report. Sometimes they will cover it up. It just depends. But there's much more transparency with OSHA for unsafe workplaces than there is for actual patient care issues and licensing investigations. Unfortunately,
Maybe they need to pay the patients and make them employees so that now they fall under OSHA.
Right. Well, that's why I always say to nurses and healthcare workers, find a safety issue, right? That's why we talked about it last week. It's like, if you're going to make an issue and it's not, make it about patient care or make it about safety, because if you make it about workplace safety and you can somehow connect it to workplace safety, you have federal whistleblower protection.
There you go.
And so that's very, very important. And so it could be, well, we're being, overstaffed. So this overstaffing is causing us to walk faster. It's causing us to then have to be able to trip. It's causing us to slip, fall, whatever it might be. Right. So
smart one right here. Smart one.
It's, so again, you've got to connect the dots. And that's what I was really good at doing. Honestly, I don't really have a channel for that now anymore. But if anybody wants help with that, let me know. I will help you. But this is how, unions can really strategize with their members about how to craft these complaints so that then you're getting the regulatory agencies involved. And then you're also having whistleblower protection as workers. Now, that does not stop you from being retaliated against. It gives you cause to create a case if you are. Because these employers will do what they do.
Well, I'm going to run away. I have reservations.
Well, I hope you have a terrible time.
Super. As it's pouring rain here and then 35-degree winds.
Hey, in my defense,
awesome.
So we're out celebrating. It's my 10th anniversary, so that's why we're on vacation.
That's very exciting. I hope you have a beautiful
it's a big
time.
One.
Yeah.
And we're at the wonderful United States Virgin Islands. So.
Wonderful.
Because where you live isn't already perfect enough. So
right.
Sucks to be.
Well, you have to go better, right? You can't go worse.
Just stay there and be a nurse in the USVA.
Well, thanks for popping on.
The best part is they just joined the compact. They're in the process of implementation.
Yep. I've known a lot of jobs. It is
There's
hot,
worse
though.
places to work.
It is
I hope
hot.
you have a lovely time. J. Michael, thanks for being here. Anywhere you want to send people?
Well, you can find my channel on YouTube at J. Michael RN. And I'm in the process of redoing stuff and getting back there and doing stuff. So I know that the one case that I'm really interested in following is the Finley and Cadigan case out of Illinois, the 2 EMTs charged with murder. I find that stuff more interesting, the legal/medical cases. So
I, for one, am shocked knowing you. Well, thanks for being here. I'll send
I'm not law nerd at all. Okay. Bye, everyone.
Bye. Thanks for being here. Yes, that's how J. Michael and I met, was all the LawTube things. I think there's a lot of LawTube people here. We appreciate you. Who else? There was someone. Boop, 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 boop. I should have started. Oh, Nurse March, Ohio. asked, first of all, I think you're doing something tomorrow. I've been trying to follow your chats in the chat while also maintaining like some focus. So if there's something you want to promote, Nurse March Ohio, also your Nana sent you, which is awesome. Go Nana. Thanks, Nana. If you like the panels, do give the video a like. It tells the YouTube gods, and then they tell other people. Also go give your Nana a like. We appreciate her. But she asked, or I don't know, I guess I shouldn't assume you're a girl. They asked, do healthcare workers need to be charged for families to sue a facility? Also, if you're promoting something, I think you're getting together or doing some kind of something tomorrow, you can let the chat know, and I'll try to put it in the description in case people are seeing it. But this is a good question for Lorie. Do healthcare workers need to be charged for a family member to sue a facility? My gut says no.
So I don't understand the question.
So like, could this person's family member charge the facility even if they never charged the nurse? Can you still sue a facility for like wrongful death?
Yeah, charge is a criminal term. So, a person can't charge a facility. They can file a wrongful death claim against the facility. And as an employee, they are responsible to cover you for malpractice unless you're acting outside the scope of your responsibility. So yeah, they can sue the employer, but not the nurse directly, because the nurses are part of the employer. Does that make sense?
Mm-hmm. It does to me. So this was basically just out of line. There was no need to. I think they were trying to see, like, could there be any repercussions for the facility if they didn't go after the nurse specifically? And it sounds like the answer is yes. That it's not like the family is just, out there with nothing if you don't criminally go after the nurse.
Well, it also depends too, and I want to, Lorie, I know you got something to say about this, but I want to point out, right, that states, because again, there are giant corporations that are owning these facilities, hedge funds, these are offshore companies that are owning these facilities, and they're bringing a lot of power to bear on state legislators to create legislation that doesn't even allow you to sue in some cases, right? We just saw a piece of legislation passed that basically eliminates the ability of the public to sue companies based on, child labor, right? So this is not, and then you're signing usually an arbitration agreement. And so it depends on what that state constitution is. Like in California, you can't sign something that violates your state constitutional right, period. So there is that to fall back on. That's unique. So again, we have to really be careful about what these laws are and what's happening in these states. And this is where we really need people to get out and lobby and start contacting their state legislators. Go, Lorie. I know, sorry, I kind of cut you off.
I don't even remember what I was going to say now. Yeah. Again, you can choose your remedy. You can go after a facility criminally. You can report them to the Department of Health. You can file a complaint against with the nursing board for the particular nurse. You've got lots of, the families have lots of options about what recovery they want to pursue. The nursing board obviously won't give them money, only medical malpractice, wrongful death will. So Maureen said, it sounds like nursing schools need to have courses in C, which I'm not sure what the C is, but you're welcome to get my book, What They Don't Teach You in Nursing School, which talks about the over 1,000 nurses I've represented before the boards and how to protect yourself.
Lorie is the answer to everything.
I think Maureen was a plant.
Maureen, for real. I wish they did go over more legal stuff in nursing school.
Yeah, they teach to the test and not to the laws you have to follow. And that's my biggest complaint about it.
Depends on the programs.
Yeah, we need more.
Well, at these graduate programs, I've seen reviewing graduate programs, some actually have a course in like how to run your little nurse practitioner business and finances and things like that, and others don't. And I don't know that that's necessarily on any of the certification exams. So there may be some of it out there, but it's certainly not consistent. And
in my MBA class, the very first class you take in an MBA most often is how that your job is to protect the employer at all costs. That's the ethics class, is that you protect the employer at all costs and the employee is always wrong. And You don't give a crap about employees. It's always that your job is to protect. And when we take the human resources ethics stuff, your job is to always protect the employer. Period. I mean, it's so ruthless.
Business, isn't it business? I mean, it's a business. It's set up to make money. You're not there to make.
But you make money through having, good, happy employees too, right? So it's but yeah, it's it's that philosophy. But yeah, I mean, we had about 2 hours in nursing school, I think, of ethics. I don't know. We got a little book to read, right? I mean, again, it's not in an ADN program. You're not going to get very much. Even in a BSN, you're not going to get very much. My MSN, I don't remember. I'm like, maybe. I mean, again, I think that we need more people like Lorie. We need to basically create a directory of Lories in every state who can then, we need to do a conference. We need to do a teach-in and really have some education in all 50 states and territories about what are the laws of this state for nurses. I mean, that's really something we need to put together.
What would really help if someone like Lorie would, I don't know, write a book that we could all read.
Well, it's state by state, though. So Lorie's an expert in her states, and it's every state has different rules. And this is the problem, is that a lot of us
write another book.
A lot of us get, we get questions from all these nurses from all over the country. Maggie does as well, Nurse Advocate on TikTok. And, we can't answer for every state. And then you get into these compact issues and you're like, nurses have no clue. You get a compact license. I mean, I'm sorry, but shouldn't there be some something you get that says, here's just an FAQ of the breakdown of each state and the compact? Nurses don't even think about it. They just go work in these states. I mean, to me, it's blows my mind. It blows my mind because I get so stressed about having a compact license. I'm like, oh my God, that's overwhelming, But again, we need to have that kind of resource available for nurses because I'm telling you, people, because there's a couple of us on TikTok who run around looking at state websites, trying to answer people's questions. There's a huge vacuum here, a huge, huge need.
There is a directory of nurse attorneys at the American Association of Nurse Attorneys, TAANA.org. So they're not in every state, but they're in a lot. And I personally have represented nurses in 26 different states just with co-counsels because there just aren't enough of us to be able to help nurses and have this background that we do. And we get it. We've been there.
Although,
what do you think?
Facts for every state are available online. So kids, if you're a nurse and you're going state to state, it really behooves you to look it up online and read your Nurse Practice Act for the state that you're working in.
Contraire, Scott. There's not a Nurse Practice Act for every state.
No, Michigan didn't have one. When I worked in Michigan,
my state
Michigan was just go forth and play, have fun.
My state sent me an email that was basically we just leave it all open to interpretation because I was like, I can't make sense of jack on your website about nurse scope of practice. It's so confusing.
Under regulations by the board, is there any? There's got to be some governing.
Yeah, they have language, but again, it's
very open-ended. It's kind of up to your discretion and the discretion of the people who advise you. And you're
just so you guys know,
something you would want to know if you're a traveler to Michigan. That is something you would want to know.
How many pages? So for folks not in California, the Nurse Practice Act is like a book. It's like a for real book that you have to buy, right? I mean, so it's not even a short. It's not even. There are some states that have a legislation about the nursing, all the licensure laws that is about 2 pages, right? The Nurse Practice Act and all the things that cover you as a nurse are very extensive. I mean, I'm just saying it's very detailed.
Yeah, it is detailed. It's not like a thick book. I mean, it's a long read. It's a PDF file. It's a long read. You have to, and basically when you read it, you go through and look at it's like when you read something for school. You look at the titles first, the introductions and the table of contents and just get an idea. Mostly the practice is the same in all states, but sometimes there's specific language about delegation and a few different things. But if you're going to travel to someplace without a Nurse Practice Act per se, all the more reason to look up that state's Nurse Practice Act and find that there is not one, so that you know what rules you're expected to practice under. That's disturbing. If that information is not readily available for each state, that's a problem. But I think I would still encourage everyone to go look for it, even if it's not there, because oftentimes you would find it. And it's something that we should know, and they should make it more available. And there should be maybe all of it in one place.
And it may be in two parts. For example, in Indiana, the Nurse Practice Act is in the statute, and the statute is what the legislature wrote. But then there are rules
California
that the in the Administrative Orders and Procedures Act and administrative rules, the administrative code, that take what the legislature said in the statute and kind of flesh it out some more in the administrative code. So there may be two places for you to look.
That's true. I forgot to mention that.
But
And
yes,
don't
this is
forget, your policies and procedures are always the key. You've got to follow them no matter what. And if you follow the policies and procedures of where you're working, the likelihood of getting before the board is pretty remote.
And I don't know, again, make California jokes, but I talked to the person at the California board about losing your license, and I made a video about it. I'm not necessarily promoting my video. I'm just saying I've actually had a conversation with someone about this who knows about this. And if she is to be believed, it really has to do with patient safety. They're not out to get you. In fact, this blew me away. I figure a license is permission by us as a society to let you do something that we want to check to make sure you're okay to do, like drive. So you want to drive a car, we have all said, we'd all like to check and make sure you're safe to drive first, and then we'll give you a license to drive, a driver license. Same with practicing medicine, practicing nursing, all these things. So I considered it permission from my society to do this job called nursing. And if I screw up, then they could say through the board, we don't think you're really qualified to do this anymore. We're going to take back our permission. They don't look at it that way, at least according to this person at the board. Your license is your property. And so to take something from you that is your property requires due process. And so that doesn't mean, we just don't like you. We're not really sure you're safe. We're going to take back our permission. It's actually, that's your property. You earned it. And if we want to somehow take it away, we need to go through due process and show that there's good reason to do that. You have a right to it until proven otherwise. So, and they are not out to get a bunch of people's licenses. They've got a lot to do. If it's a DUI, if you have domestic violence, if you have a really serious felony outside of work, yes, that's reason for them to take action. And if it's at work, it's got to be something around patient safety. It's not that you show up late every day. You don't get your license taken away for that, or that you come in with dirty scrubs. I mean, that does maybe speak to infection and patient care, but it has to really do with patient safety. That's what they focus on. It's not us talking on YouTube and people disagreeing with what we say. At least that's what they tell us. So that should be reassurance to everybody that if you're practicing safely, the only reason they're going to come after and take your property away from you is if you've done something that affects patient safety. And hopefully it will never come to that. But just to give you some reassurance that no one's out to get your license, but it's like I always say, it's really hard to kill a patient as a nurse. It can be done, but it's not something that just happens whoops. To make these really big, serious mistakes are not things that you just will kind of, I forgot to do something. It's more involved than that.
And for the residual anxiety that doesn't take care of, there's Zoloft. Okay. So most of us
don't
are
let
on
anyone know you're taking it.
I was thinking about just becoming like a marijuana nurse or something, a cannabis nurse. I mean,
I'm not sure you can use on the job though. I'm not.
I mean, it's.
I mean, you could be a methadone nurse too.
No,
but
I'm just saying,
saying
there's a lot of options for nurses. There's that are less stressful environments.
Yeah.
So it's. I actually saw a bunch of jobs for it. I was kind of surprised.
I feel like that's going to be the next evolution of your life, Adriane, is you're going to go up and open this empire.
No, it's not happening in Virginia. I can tell you
that's
that.
True. That's very true. You don't live there anymore.
Yeah, I live in the land of Mitt Romney Jr.
That's very true.
Mitt Romney wannabe governor, Mr. Nice Guy.
Maybe that's what will grow on my homestead.
I'm down with it. Yeah, it's
Pennsylvania's not down with it either. They're like, no, big no. We don't like it.
It's coming. Yeah. I think it's, I think that's a whole other issue, right? It's like drug testing and all that stuff, right? That's a whole topic unto itself, that you can just do the hardest drugs possible and not have it show up in your system. And then really ridiculous things. This is why nurses drink. This is why nurses drink.
It's also why nurses should have therapy. Just to make this a little bit serious, if you need Zoloft, you should take Zoloft.
Yes,
and if you need some
do.
therapy, you need therapy. And if you need a mentor, someone within the profession that you can confide in, or even fellow nurses who are just as experienced or inexperienced as you are to bounce things off of, that means a lot for your mental health. And that's important because good mental health is also a way to prevent errors.
Mm-hmm. And Scott, I just wanted to also say, so Adkip said all the California jokes are jealousy. And I also just appreciate you being willing to go against the grain of everyone else, because I know we all disagree with you on certain things. And I legitimately appreciate you standing your ground and being like, no, because I want this to be a space of like multi-cornered conversation. And it's uncomfortable to sometimes be the person who's like, no, I really don't think that way. Like, here's my other viewpoint. So I just want to say thank you for being you and being willing to do that. And
I want to let you know too that if you say something that makes me rethink my position, I'm completely willing to rethink my position. So I hope it is a dialogue in both directions.
Scott brings balance to the force.
Yeah, I'm the dark side.
Well, we all are continually learning here, and everybody who's not even on here who's joined us in the other live streams. We all, of course, are up here because we have strong personalities, right? And, but it's about respect. It's about, what can I learn? Let me open my mind about something, be exposed to something different. And it's that sharing and synergy that is hopefully what makes these, popular. I don't know, Liz, are they popular? I don't know. Like, it depends on the topic, but, view it. Yes. Viewers, it's up to you. Make this popular. Share this live. Share this live to 10 people right now.
Good.
There's a list of people right here that are interested in what we're saying. At least they haven't left. And
we appreciate these people.
So, thank you. Yeah.
And
as really good topics. And I'm so glad I got involved with you all like a year ago, because I wasn't really politically minded and want to change healthcare and all that. I mean, I wouldn't defend healthcare as being perfect, but I wasn't really, plugged into a lot of the issues. And, interacting with you all and hearing that's something that's very important to you has taught me a lot. Because, as I said, I've worked at really good places, so I've kind of been sheltered from that. So maybe that's doing the same thing for some of the people that are tuning in. It's like, I never really thought about how broken healthcare is, and you made me think about that. And that's what we aim to do, I think, is for people that are watching, like, make you think.
And we haven't even backed on you for being an ER nurse and only really seeing the front end of things, right? So,
and as much as Scott and I disagree with each other sometimes, we spend a minimum of 2 hours a week together on the phone. We just call each other up and say, "Hey, how's your day?"
Yeah,
so you guys really are cute. Friends. You guys are like full bromance.
We really are friends.
I love it.
It is. Yeah,
I love Scott. He's my bud. I love Scott.
Yeah.
I'm not gonna lie.
We all like each other a lot, you guys. So even if we like dispute and argue, we all like each other quite a bit.
And I think we all have some really interesting stories to tell about, like our life story, like Liz going in and out of primary care, and Mr. Midwife having to go 3,000 miles to find a preceptor for midwifery school, and Nurse Adriane and all of her adventure, all the places she's gotten fired from, and my
never as a nurse.
Never. Okay. We've all gotten a lot of different experiences, I think, that make these really rich conversations. And Nurse Chelsey, who's supposed to be on here with us, is another good addition to the group.
She's very mild mannered.
Yeah.
It's really hard to get her to talk, though, because she's
a church mouse.
She's
a church mouse.
It was just last week that she was like, no, she disagreed with me. And I was like, I'm trying to break down those barriers. I remember you. She can hold her own. Don't let her fool you.
Also, I feel like I didn't ever know this degree existed. Ms. Melanated said my girlfriend is getting her degree in robotics in December, and she's getting ready to make a major pivot. So if you need a different career, if this whole conversation has made you be like, I think I'm going to do a hard pivot out of nursing, robotics is on the table, friends. I didn't even know robotics was on the table, but it is on the table and apparently thriving. So,
oh yeah, robotics. Look, I wanted to bring up, I was just perusing jobs, as I do occasionally, to see if there's anything interesting. And I see this job, and it's for long-term care. No, was it long-term care? But it's basically to be, because it paid really well and it caught my eye, to be a virtual assessor, like to assess patients virtually, including charge nurse, because I only put remote, but sometimes they put, things aren't really remote. But I thought, so you want, this again goes back to that, like, I'm going to be on camera assessing a patient, right? or being a resource nurse to other staff, and then being charge nurse and doing it like from a computer somewhere else.
That's wild.
Yeah. This is where healthcare is going, you guys. I'm telling you. It's, yeah. So
you can have your charge nurse breathing down your neck and not even be in the same room with you. That's not right.
I mean, yeah, it's pretty wild. I was like, it had so many different job descriptions, but I just would caught my eye that it said charge nurse in there, in addition to like assessing patients. And I think this is another rabbit hole, Lorie. I don't know what you think, but if I'm taking a remote job as a nurse and I'm doing some kind of assessment, I don't know. And also, if I'm in different states, where do I get sued? Where am I liable? Right? Then can I force federal court like some travelers do? Right? Because, some travelers are kind of lucky that they can they're testing the legal system by taking things to federal court. But I don't know, Lorie, what do you think about that as far as that liability doing remote kind of assessment work?
Yeah, you have to be licensed where the patient is, period.
Right. But I mean, as far as like where am I located? So like if I'm located in California, but I'm working off my compact license in Mississippi or wherever, right?
You get sued in Mississippi.
Right. Okay.
It's the state where the act occurred.
Right, where the act actually occurs. Okay. But what do you think about that?
California.
But what do you think about that liability of that type of job as it's really expanding quite a bit?
The issue is not so much the liability, but if you have multiple licenses, if action is taken in one state, it'll be taken in all of the state. I call it all the states. I call it the domino effect. And if you have a compact license and have discipline on your license, they will revoke the compact.
This is why you need a side hustle, everybody. Have a side hustle that has nothing to do with your license.
Or nursing. It's more fun when it has nothing to do with anything.
Side hustle, yeah. I mean, it's just getting to that. It's just getting to that point, right? It's just getting to that point. But I am concerned about it because I think that that's going to be another area where there could be a lot of liability for nurses or any staff really who are doing any kind of remote. The issue of remote monitoring, that comes up as well. So what if you're offshore, so what if you're in the Philippines and you're doing remote patient monitoring? Well, you are licensed in a compact state or in a particular state. However, again, there's just a lot of like gray area to me legally on this, and a lot of squirrely area.
And as a provider,
no, go for it.
As a provider, I'm okay with doing a few things remotely, but ultimately, especially in my profession, I've got to put my hands on my patient. There's something that's lost with the human touch not being there. You can describe it all day long, but I really need to put a stethoscope to your chest. You can describe what's going on with your body as much as you want, but I really need to look.
But if it's a job that's more of consultation, I know none of us do mental health, so it would be
smart ass.
Oh, you just
Chelsea. I said on my patients.
If it's more consultation, if you're doing patient education, maybe you're hired as a patient educator in your specialty. So that's something that you could do easily remotely.
And like I said, there's some
that would be okay.
niche for it, but
yeah. And then that brings up a
agree.
good point. We need to know, I think the telehealth companies now are requiring that you're both in the same state just to avoid this kind of stuff. But it'll get to the point where they'll go offshore, they'll go cross state lines, and then where will we be?
Well, I think Liz would agree. She's a nurse practitioner.
Well, we've been there for the last 3 years.
Someone's chest. You got to put your hands on your patient.
Oh, yeah.
And I can't deliver a baby by remote control. Even with a master's degree or a doctorate in robotics, I still have to be there.
Well, maybe they can create a robot, a robot that you can control remotely and deliver the baby with that robot.
So Aaron asked about, can you report things to risk management without losing your job? I just want to address this. So Aaron, I would again go through and assess, is there a way to link this patient issue to a worker safety issue? One. So can you link it to worker safety? what are the laws of the state that you're in as far as patient care and patient safety standards? What is the language and licensing, the state licensing laws for the facility that you're speaking of, right? So is there some way that you can connect it? And what are the whistleblower laws for your state? I think compliance lines are complete rubbish and meaningless. So I never advocate using compliance lines unless you are also going to first use the state and contact OSHA, contact your state licensing department, because then you have whistleblower protection typically. But again, check with your state, because you don't want to do a compliance line. It's an internal system. I know the company I worked for, if you went to the hotline, it did go to corporate, and then it came back to HR, which was interesting. It would go to HR to be solved, even if it was a patient care issue, and then HR would do their investigation. I mean, we would do this on purpose and file things and then actually follow the steps, right, and see what happened. And it just was such rubbish. So HR would do investigation on a patient care issue that they're not even qualified to address. And then they, of course, are going to come out and say, well, of course we did nothing wrong. And, then, oh, wait, we're going to write you up for some BS reason, right? So again, it's all rubbish. It's all rubbish. Makes sense.
It kind of makes sense. If you lodge a complaint about something that's going wrong in the hospital, the first thing they're going to do is, can we blame the nurse? Let's send it to HR. That makes sense. That's the first place to go, because the first thing is, who can we blame? Well,
but it's just not but think about it, in other industries, it actually doesn't work that way. So if you file a complaint in some other industries, there's actually mechanisms where they go to the people that are in charge of that area, right? It's like if you're for example, in oil rigs, in the oil industry, California, we have a lot of oil refineries, right? If you file, complaints in some corporate compliance, often it's going to go to that division that handles that issue, because they're mandated to do that under OSHA, right? Because it's a worker safety issue. But so again, we got to look at what are those, think about other industries and what they would be doing. And does it make sense when we're talking about human beings are the product and patient care is the product? So if somebody's lodging a complaint about patient care, why are we bringing HR into it? It's not their issue. But I think a lot of times HR it's just the culture in hospitals and healthcare that is, so punitive. It is designed to be so punitive.
I would also suggest, if you do have your own insurance, that each of your insurance companies have their own risk management. And that way it's completely confidential and you can ask your question and then get support that way.
Are you saying your healthcare insurance compliance?
No, your own personal malpractice insurance.
How would that work? March that out for me. How that works.
So say you have a concern in your hospital that something is, it's going to get you in trouble, in your hospital in trouble. You can call the risk management for your own personal medical malpractice carrier and ask them their advice on what's the best way to protect yourself.
And also, if something is Medicare fraud, then that's a whole other hotline that you can utilize through CMS. So Medicare fraud, that's another one of the the third category that you're highly protected in. So if there's Medicare fraud going on, oftentimes nurses will be the ones that be aware of that. They'll see things going on. They'll hear about things going on. Doctors getting kickbacks, or see things getting billed for things that aren't actually happening. That you definitely should be reporting that.
I'll try to find a link for that. That's what I was writing a note for, was how to find link to how to report things to CMS.
That sounds like something you get fired for. Oh, we got somebody who's reporting to CMS. That's a nurse that needs to go away.
No, that's a big CMS. So when you report to CMS, so there's, and I can't remember the percentage. If the facility is found, or the individual doctor, whoever is found to be guilty, and there's a measure of how much they have embezzled from the federal government, then the person reporting gets a percentage of that as a finder's fee.
Oh, so you actually there's your side hustle.
So remember the case I told you about, the HCA hospital in Vegas where the FBI showed up. in semi trucks and removed the entire medical records department in several semi trucks. That was from whistleblowing, and then they were found to have been, misappropriating millions and millions of dollars, doing kickbacks in the parking lot. The photos of doctors taking cash payments to do heart surgeries in the doctor's parking lot, things like that. So those kind of cases, the FBI, I mean, if there's a big hospital, I mean, this was a Sunrise in Las Vegas, then they will come in. The feds, this is the FBI, they will come in. They will investigate. That's the Department of Justice will come in if it's a big case. So there is whistleblower protection for that. I will also say, and in my MBA program, if you're not a staff person and you are reporting this, you should plan on resigning. That was another thing in my MBA they actually talked about. There was a big chunk of my class. If you're going to report your employer, then you are going to resign. You're going to leave. So if you're not staff and protected as an hourly staff. Just an aside.
If you're not
just
staff,
as a fun fact,
if you're not hourly frontline staff, if you are considered management staff, if you're considered exempt management staff, then you should be resigning.
Yeah, because you're implicating yourself, right?
Well, no, it's just that you're going to be persona non grata in that organization, and they're going to figure out a way to fire you.
Well, that was my point. As staff, you're going to be the same thing.
But no, it's different because it's a lot harder when you're staff. It's just it's a lot harder. There's different protections. If you're staff or you're exempt or you're hourly or you're considered management. In reality,
I think sometimes they find ways to get rid of you.
Oh, sure. Yeah. I mean, that's definitely why you have to cover yourself. You've got to make sure that you let your employer know, hey, I mean, if one of these things are anonymous reporting for one, but if it does come out, right, then, you have to fight the good fight. But if the whistleblower protection, it really kicks in after you're fired. That's when it really kicks in. And you're using whistleblower protection is that you've been fired. So, so it's a little hard to explain that nobody's going to come protect you before you've been terminated unless you're part of a union. So it kicks in that you have that whistleblower protection in the event you are fired. However, if you're management, there's just, it's perceived differently. It can be perceived differently.
That makes sense. Thanks.
Lorie, this was a question for you. Is it the same thing? Nurses taking care of patients in homes that put nurses at risk? You should ask your own insurance as a nurse.
Yes.
I guess.
Any question you have about asking, any question you have about whether your license is in jeopardy or you could have malpractice, that's what the risk management for your own insurance company is for. You can ask any of those questions. But if you are working in a situation where you feel like your license is at risk or it could be malpractice, then don't stay. Again, you can always get another job. You can't get another license.
Mm-hmm. And again, guys, if you guys have legal questions, cannot recommend enough. Just go peruse Lorie's website. She's got all the things. She's got tons of stuff for nurses. If you're a nurse practitioner, all the things. Go look and learn and feel better about your life or feel worse, depending on what you're doing. But go check it out. I will have it linked down below as soon as this is over. Also, look who's here. Look who's here.
License protection site, that's at the top right. And so just look at that other. I do a blog every week. This week was about the case that we discussed. So it was perfect.
Lorie, is the best place to get to you on LinkedIn to kind of keep up with your content?
Well, I can't say I'm great at it.
Okay. Just go directly to your website. It's better.
Yeah, I'm not big on the socials. Sign up for something. If you sign up for that free audio, what happens if I get called before the board, you'll get on my list and you'll get an email every week from me.
Yeah, awesome.
Right here. And here's our book. All the things. We appreciate you. And it sounds like there's more. We need more nurse lawyers. So if any of you are highly motivated, Adriane.
I'm so broke. I'm so broke from my MBA.
We'll take up a collection.
That's what GoFundMe is for.
Yeah, and you can go support Scott's GoFundMe to get him through nurse practitioner school so that he can enter the workforce and then get really jaded just like me and then it'll be like a cyclical.
No, I can contribute to Nurse Adriane's GoFundMe to get her through law school.
I don't know. God, I'd have to go to like an ABA law school. It's going to be tough.
And I also found, where did my link go? If you're in Ohio, this is the Nurse March Ohio. So I will leave this link down below too. So you can look at all the different, obviously, like we need, a lot of this, like we were talking about, the litigation side of it usually goes back to like things probably not being ideal on the nursing side of it. So this is how you can improve things. Here, go find this right here. And also, thank you. Where did we have Maureen for shouting out Nurse March Ohio? Nana,
I think they're
to the
related.
rescue. They are. I think Maureen is Nana. There we go. Yeah, so go check that out. So. Thanks for organizing this. We need more people like you in the world so that we can make change and do the things. Chelsey, do you have any thoughts? Probably not.
Well, I just came in to talk about robot babies, really. I didn't get to see the first part of
really, I don't know why we're here, but I'm more focused on robot babies.
First part you missed I did a really good job of getting the entire chat off track.
I really appreciate
it. Yes, you did.
It was very difficult to maintain.
I've already like imagining like a doll, a robot baby doll, like one of those bobblehead things,
Listen, just look it up.
Nora made a comment about using solder and a soldering iron to solve the episiotomy.
I mean, I'm having flashbacks though to using the Sims and giving birth, in nursing school.
And do you know what they're doing now? They're going to have virtual reality nursing clinical. That was on my original list of things to maybe discuss. So maybe we'll talk about it on Tuesday. They're doing VR now for a good majority of your nursing school clinical. So
for the majority of clinical,
No,
for clinical, I think is depending on your state, up to 50 to 75% of your clinical can now be in a simulation lab.
I'm out.
So VR,
50% where I'm at.
Mm-hmm.
So like originally I was thinking, oh, this would be great. Like as a nurse educator for like me with my nurses who are like working every day, that might be a good thing. I can walk them through delivering a baby or something, but not like not like when you're first learning.
Not pre-licensure, no.
Not that's
as refresher and stuff.
Something else entirely.
I'm just imagining how much fun I would have as a nurse educator and how quickly I would get kicked out of a program because the students would walk into these insane situations in their VR and I'd be like, there's just like everything everywhere. There's so many fluids, and the people would be like, oh.
We were pretty crazy. We were the first group to get the Sims. And we had actually a unit on a hospital that was closed. That was our nursing school because they were able to add us. So we never actually went to the actual college, but one time in 2 years. And then nobody knew how to use them. We had like, I think 5 different clinical instructors over the course of our first semester. So we never even knew who our clinical instructor was going to be. And so we would just be like waiting an hour or two because we had 12-hour clinicals. And I could just say we were completely 100% inappropriate with the sim dolls, the body parts, what we made the doll, like all of it, how we spoke through the dolls. I mean, it was just, when left to our own devices, we're going to do whatever we can to make ourselves laugh. We were already in nurse mode. But yeah, occasionally the teacher would walk in and we would just be like, no, we're not. I don't have a baby coming out between my legs. That's a fake baby. And somebody's screaming through the sim, like we would do chest compressions on the Sims and then we would like try and distract each other. So it was good. It was real life, occasionally maybe somebody's, other things may have happened. I don't know. But, it just like, it would be a total distraction. Like we'd be blaring music, screaming at them. And, because it was this closed unit, so nobody could even hear us in the rest of the hospital. It was like, we're just like we were just left to our own devices.
You're a mess, Adriane. You're a mess.
It was a hot mess. Yeah, it was a hot mess.
That's a lesson for nurse education.
Then we had this awesome woman who taught us clinicals, and I don't know if she wasn't German. I don't think she was Swedish. I'm not exactly sure, but she was so serious about like all the safety stuff. Like she literally made us practice carrying each other down the hallway, and I was like, and I thought that was normal. And I literally don't know a single other person who had to do that as like to practice caring patients, like in a
survival
fire.
nursing school.
Like I'm pretty sure maybe she was a child in World War II. I don't know. You know what I mean? Like it was basic. I mean, like, you know how, I mean, if you've been to like Germany or Switzerland or Sweden or, you know, Finland or some of these countries, right? That
they're like,
they're just like take things, the procedures very serious, right? And so we were like, all right, sure, we're going to, you know, and I was like, you know, we'd like try legs over the shoulders, you know, body over here. I mean, like all these different ways, like, and
so then were you the person like at your first nursing job and you're like, you remember that day in nursing school when like you had to like buddy carry your friend like down the stairs? Like I've never recovered from that physically. And everyone's like, wait, what?
I literally have not met a single person who had to do that in nursing school ever.
We did that in EMT school. But
I mean, I think EMT because you actually are for sure. No, you're going to have to deal with stairs as an EMT, right? But like, I just thought everybody did that. And then I found out nobody ever has done that.
You didn't actually go
like I have photos of like,
here's the thing,
people over my shoulder and we're like, you know, doing drills. And she's like, you have to get in shape. You must work out, do push-ups. You're going to have to go down many flights of stairs. Like this was imminently going to happen, you know?
I don't think you went to nursing school.
Where did you go to school again?
What you went to was not nursing school.
But we've known this. Her nursing school was different anyway, in other ways as well. Like we've known this for a while.
So many ways.
And then we had another instructor who like took us. So I went to school in Manhattan Beach, and you guys remember Billy Banks, that fitness guy? What was it? That thing? It was not Zumba, but it was that other workout thing he had. And so his studio was right by our hospital we were in. Tybo, yes, Tybo, the Tybo dude, right? So we had another like clinical because again we had 12-hour clinicals. Teacher's like, oh, we're gonna end early, like at 4, not 7, and everybody meet over at this address, right? We proceed to do like an hour and a half Tybo workout with Billy Banks. Like, I mean, we're like, we're dead. Like we're dead. I'm dead. Right.
Just so everyone knows, Nurse Adriane kind of went to nursing school on Mars. So
I don't know. And I went to a great nursing school, learned a lot. It was a great experience. But yeah, I had some pretty. They did try and make it fun for us.
We are my only thing that I remember from nursing school with like the sim lab or the dummies. Like it was a very long time ago, but I thought Mr. Midwife and Chelsey, you would appreciate this. Our pregnant one, whenever it had a baby, all it could do was push, like, because it was very old, but its head fell off whenever it did it. So if it pushed it out, it was like, meh, and it would just make this like this awful sound.
All we had was the fake pelvises that we would put the Foleys in.
You had the South Park Sim nurse.
We did.
With the interchangeable genitalia. It's like, are we doing male or female? Okay, yeah.
And we had to wear pregnant bellies for like a day, like to school.
Did you guys have the old people suits where you had to like put on like
someone
the body
said that
suit?
they had a Jerry suit.
We had Jerry suits.
Audrey, we had to wear a Jerry suit to simulate
like crazy glasses and
I got hired at the same hospital in LA twice. I left and then did some things and came back. And so I had to go through orientation again twice. And they both times did this thing. It was an empathy. It was meant to give you some kind of empathy. And they did what I imagine is the same with these Jerry suits. Like you had to wear these glasses that they had scuffed the lenses up. And then you had to, they gave you some jelly beans and you had to divide them by color. And it was like doing pills when you had glaucoma or some, or cataracts. And the other thing you had to do is they gave you a Foley bag with nothing in it, just the Foley bag itself. And you hooked it on the side of your pants. And I guess you stuck the tube in your pants or whatever. And you had to walk around the hospital campus for like 15 minutes with it. Just to give you an idea of what it's like to feel self-conscious.
Yeah.
And there was no pee in it. It wasn't actually in your bladder or anything. It was just a Foley bag. Just to give you the kind of idea of how patients can feel self-conscious, with medical equipment. And I'm not sure if I thought that was brilliant or not, but they did it for many years in a row, for sure.
My school, so Irene had to wear a colostomy bag filled with water. We had a simulation lab with a colostomy bag, but they put pudding in it, like chocolate pudding, and no one knew. So you walked into the sim lab and the person just like exploded it all over. And it was supposed to be a thing about like having therapeutic, like how to communicate when gross things, like when unfortunate things happen.
This is why VR clinical is cool. This is
well, like that was my thing when I was in nursing school. When you walked in and the colostomy bag exploded all over you with pudding. And you had to like communicate about it?
You can't virtually stand in what Liz has referred to as the splash zone. That has to be experienced first.
Well, and then I went to work in GI.
No, but we could do VR, and then I, as the educator, can splash water on you at the precise time so that you get amniotic fluid on your bra and underwear. God. So,
yeah, I think it's there is no substitute for being with human beings on a floor in a hospital and seeing all the different things that go on. And you're observing, the workflow and time management, and there's so much you're learning.
Interaction.
Right. And you're having so many opportunities to engage, and you really learn about how to communicate with patients of different ages. I mean, that was.
Yeah, I mean, I don't know. I was a traditional student, right? I was like 20 years old in nursing school. So I didn't have a lot of experience talking to a lot of different people in the world. And now I have, but at the time, how do you talk to an old person? How do you talk to a kid? How do you talk to someone who's dying of cancer?
Mm-hmm.
Young
people, I think, are really challenging. It's especially when they're in the hospital. Like, it's true what they say, right? Like, they kind of shut down. They get really avoidant. Our colostomy bag was filled with oatmeal.
Yeah. Nice. But hopefully you have an instructor that helps you, encourages you to just try. Maybe you say the thing, you don't say the wrong thing. It's not quite the perfect thing to say, but do it anyway. Go in, talk to your patient who's dying of cancer. You don't have to talk about the cancer. You talk about what they're going to have for lunch or something, but just interact with people. And hopefully you have faculty that'll support you.
And you're going to have those awkward moments. I mean, one of my very first patients was a young person, a young man. I don't even know if he was 18, maybe 18, 19, who was there with had an orchiectomy because of an ingrown hair. There's not a lot of therapeutic communication you're going to do to somebody. I saw that twice in nursing school. And, sometimes
for an ingrown hair.
For an ingrown hair.
Very ingrown.
New fear unlocked.
Grown all the way in.
You don't want to be pimple popping. Or young guys are not that clean, right? I mean, it's so, but it's like sometimes you have those awkward moments where you're just like, yeah, this fully sucks, and I got nothing for you, buddy. And you're just gonna be there with that person, or you're just like trying to make them laugh, doing something ridiculous because there's really you're at a loss. I remember even being at a loss with this kid, like, wow, this, like, I hope his mental health is okay, right? This really just sucks. So.
Well, and this is where, for me, the telehealth and sim labs and stuff falls apart. You need that human touch. You need that human interaction, face to face, in the same room.
Although you have to meet people where they are. And if someone isn't at a place in their life and their brain to actually come into an office, the next best thing might be a telehealth visit. And maybe that can be the bridge to bringing them into the office. In that case,
absolutely.
Maybe it's useful. As a complete substitute, no. Yeah, there's nothing like sitting down with someone, especially when you're dealing with physical things. I do my therapy by telehealth. So I talk to my therapist just like this once a week, and it works fine. I did meet in person when we first started working together, so maybe that helps. Like, I know what he's like in person, so I don't, but for some things it works, and for some things it doesn't.
I mean, I think that there's that, for rural health, it's great. I think that there's definitely the application, but the optimum is going to be at least to see somebody in person, once a year, right? To see that person live or have an initial live visit. And I think bridging that. So I think there's a hybrid model that can really work. It's interesting, though, because for chronic care management, for example, which is covered under CMS for Medicare patients, is that patient to qualify has to have had a visit with a physical within 1 year to qualify for chronic care management, which then is also remote patient management. So it's very interesting. I don't know how that will work with this remote care model because patients won't qualify unless they change that rule. But I think there's a great opportunity. It can expand healthcare if somebody is far away can't, there's the application. It's just like, are we going to make that the norm? And I think that that's the wrong. We're going to just see people in the ER. We're going to see bad outcomes. We're going to see people on all kinds of meds that they don't need to be on. And I think we're going to see fraud. I think that that's another component we're going to see is there's going to be fraud.
It kind of gels with, or kind of is related to something someone asked in the chat about AI and telehealth and all. They're just tools, just like decision-making support with computerized decision support, where it helps you make sure you don't order the wrong dose of medicine. It's a tool like electronic health records. It's a tool like UpToDate, when you look up things online, which I'm learning to love.
I love UpToDate.
They're all tools for us to use. Virtual reality, all tools for us to use. Matters how you use them and in what combination with other things. Rural health, telehealth may be the best thing. It's not perfect, but you don't, again, let the perfect be the enemy of the good. It may be a bridge to bringing them in. It may be, I'm not sure if I should come in or not. Well, let's do a telehealth visit first. And then I can say, yeah, that really is something I need to see in the office. Or no, it looks like it's okay. Call me if it gets worse. And it saves you a trip 2 hours away to the doctor's office. All these things are just tools. And it's really are we going to have the wisdom to use them the right way and still maintain high levels of care, empower patients, all the stuff that we try to do, as healthcare professionals.
Agreed.
I haven't used virtual reality. I've honestly never even put the goggles on. I have no idea what it's like. I'm not sure how you would use that in nursing education, but
well, I can see again, like Chad is saying, like Mr. Midwife is saying, is like after you are already licensed, like robotic surgery, right? So doctors doing surgeons doing robotic surgery, right? They're looking through their virtual space and then they're controlling something somewhere else. But again, that's a procedure. So it's very different than you need to smell that person. You need to see how they appear. Are they disheveled? What do their feet look like? Are they clean? Are their hygiene? There's so many factors. And then I think also what we're going to miss and a big risk here is screening for, abuse. I think how do you do that if somebody's in their home and then you're not able to actually you don't know who else is around them, confidentiality. So some of those issues, it's impossible to mitigate. There's no way to mitigate that in some of these cases. It
depends on where options are too. Like you can't just say, hey, let's have volunteers come in and we'll practice a surgery on them. That's not ethical. And maybe it's not a surgery you do very often. So, you don't have an option, but to do like a virtual surgery to train on that. Other things, it might be like, there's no reason you can't put nursing students in hospitals to do clinicals. There's no reason to say,
not at all.
During COVID, there was concerns. I get that. But now I don't think you could.
I could see it for actually, once again, somebody's licensed or they're at some stage in their nursing, school after they already have the basic foundation for wound care, for example, to learn different types of wound care where you may not see that kind of wound. Or I know a lot of nurses in my unit in telemetry were going to ICU, and then for some reason there was no vent patients for months. There were certain types of patients we didn't see for months, and so then they could not get through that part of their clinical training to and so I could see it where we can't meet this clinical training component, and then here's this backup now of you're going to be taking care of this ventilator patient, you're going to be doing this kind of wound care, because again, somebody might go years and never do a wound vac. Because I know that was the case, or some basic kind of procedures. So I can see the value there for sure. I just don't think that to start somebody, there just needs to be a law against you can't do that until you have 1 year of clinicals. It should only be the later part of clinicals at that point. I don't see how that's gonna work.
Or situation specific type of things where you want them to be able to, like we do now with codes, we don't want you to do that on a real human, but you can see what it's like in this. And I think we'll talk about it more. I was going to have it maybe next Tuesday or Friday. We'll figure it out. But we have to wrap up because I have to go somewhere. But I don't have an eloquent way of ending things. But thanks for being here, everyone. and sharing all of your insights. My husband just texted me. He's like, "Are we leaving now?" And I was like, "Oh, yep, we are."
Oh yeah, gotta go. We've been chatting for a while here.
I know. It was a good conversation today. Thanks for all your insights and help and all the things.
Thank you.
Don't get arrested.
Thanks. I want to thank. I think the folks watching have been really involved today and asking lots of good questions. And that's something we've talked about behind the scenes. If you're watching this in live, when it's live, we really like taking questions and comments from you guys. So please participate in the chat and make this, be a part of it.
It makes it much more entertaining.
It does.
It does.
And then we don't follow my squirrel thoughts that are like bing, bing, bing. They like have a more focus.
Then we don't have to listen to Liz talk about her broken toilet seat,
which is still not fixed. It's fine.
Oh my God.
Oh my word! I'll come over on Saturday and fix it.
I'm driving up. Are you kidding me? What's going on?
It's a 2-minute fix.
Right.
Currently, we can't because it's serving as the house for a bunch of other animals. It's like the roof of the house has become the toilet seat. So I actually did go to figure it out yesterday and watch a YouTube video on it. And then my 5-year-old was like, "That's Stuffy's house. Like that's the roof." And I was like,
"Oh my
okay,
God,
that's fine."
That's hilarious. Everybody have a great weekend.
Thanks for being here, everyone. Go check out everyone's social medias, resources, all the things. And remember, don't get arrested. It's gonna be fine. Remember, you are not alone. We're all scared of being arrested for doing our job and making small oops. It does get better. And remember, mental health, that helps. You're not alone. You are more than enough because you really are. You're most of the time, you're totally fine. And you can do hard things. All right, friends. I'll see you next time. Bye.